Thank you, Priyanka. Good afternoon to everyone. NABH welcomes you all on the day 2 of the virtual certificate course for migration to edition of Hospital Accreditation Standards. On day 1, we learned about the journey of the 6th edition of standards and the key changes in the 6th edition. So we have covered chapter 1 AAC, chapter 2 COP, chapter 3, chapter 4 and chapter 5 which is IPC. NABH Secretariat has also shared with you all a transition plan from the 5th to the 6th edition. So in today's session, we'll be covering from chapter 6 to chapter 10. Our team will also be updating you with the digital health programs of NABH. We are joined today by our esteemed faculty members, Dr. Sanjeev Singh, Dr. Rajiv Kumar, and Madam Binamma Kurin. So moving forward, may I please request Dr. Sanjeev Singh, sir, to start today's session with Chapter 6, PSQ. Over to you, Sanjeev, sir.
From your side, and thanks for those opening and introductory remark. And thank you all the participants to have you back today. We will, sorry for a late start. WebEx and technology generally has its own glitches. So without wasting any further time, I'll get started with patient safety and quality improvement chapter. Can we get into the next slide? So more or less, most of the programs, most of the standard, most of the objective elements remain the same. There are a few things which have been sort of added just in an interest of raising the bar. But otherwise, we start with a structured patient safety program, which was there last time. Just a note before we get started, most of the time, what we generally see is all the PSQ chapter, the concentration is on PSQ 3, where we get the indicators, both for clinical and managerial indicators. And that is where most of the clinical continual quality improvement or PSQ starts and ends. But it is very important to also look at one, the tool and its application, and PSQ 1 and 2. So there needs to be a patient safety program. Next slide. And the assessor is going to check with all the standards. So you might have an indicator, you may not have an indicator, but it would be extremely urgent and important to have a quality improvement, which is PSQ2, and patient safety, which is PSQ1. So here everything remains the same. The only thing which got added is the patient safety officer shall be a person having good knowledge. So, and it reports to the top management. The roles of responsibility should be defined. So it would be again critical to just understand that anybody or cannot be a patient safety, because it's a very important and a critical post. In the 5th edition, it was written as a designated patient safety officer coordinates the program and also implements the program. So that has been merged into one, that he coordinates and implements. So that may not be two, because that is how we see it, and that's how the objective element got merged. But it would be critical that they report to the top management, and there is a person who has good knowledge and also passion. Next slide. So next, it could be a doctor or a nurse, and again, very important to the risk management is critical for their understanding. So right now, we just apply some of the tools. We don't get into understanding the various kinds of mild, moderate, or high risk as per the ISQA definition. So those needs to be importantly highlighted and understood. Next slide. So PSQ1 E, where the proactive analysis of patient risks and making improvement is needs to be done. Deepthi, Priyanka, I think they are saying that the slides are not visible. Is slide available and is visible to all of them? Am I being audible to all of you? Can you have a look? Can you do a quick check?
To us. and I believe the slides are visible to us, and people are also writing that it is visible and audible both. So,
Perfect. Perfect. Thank you so much, and I'll get started. So, PSQ1,
thank
where we are looking for proactive analysis of patient safety, it has been moved from excellence to commitment, because that is how it has been realized that it is no longer at the surveillance and reaccreditation level. Next slide. So 1F, we are looking at basically that these programs are reviewed and being prescriptive enough to put in once in a year. What was there last time is that the patient safety program identifies opportunity for improvement, and then there needs to be a proactive analysis for patient risk and making improvements accordingly. So both have been merged, that it needs to be reviewed, and then there needs to be a proactive analysis. And what is important again here is there has to be a continual review of evidence and science and the work which has been done globally, and those literatures needs to be sort of get ingrained into our patient safety program, looking for those opportunities. It could be clinical, it could be non-clinical, it could be for OP, waiting time, critical equipment downtime, medication errors, looking at door to needle or stroke analysis. So those have been sort of merged together, and one objective element is there. But all of it, whatever is done, goes through the patient safety team to the safety committee for analysis, and opportunities for improvement needs to be there with a prescriptive time of once in a year review. Next slide. So review and updated, we have already covered. How does it happen? It happens through so basically patient safety program would be divided into three. One is facility safety, second is patient safety, and third is healthcare worker safety. And these three programs needs to be done either through an inspection, through interviews, through regular audit, or through a very active analysis. Risks needs to be understood, and opportunity for improvement needs to be sort of taken. It goes through the patient safety officer and his team to the safety committee. Next slide. So we look at, I'm again repeating, most of the time PSQ is limited to clinical indicator, and that's how the presentation starts and end. There needs to be a separate patient safety program, which is important because it's written that it is developed, implemented, and maintained. And then there is a complete understanding of it at an institutional level. Now, so that is important. Similarly, there needs to be a quality improvement program which is continual in nature. Because if you are looking at discharge process, what is a QIP which you have undertaken, or you're looking at contrast extravasation, or you're looking at doing the operation theater scheduling, a quality improvement program should be there, and it should be monitored appropriately. Next slide. So this is something new which got added this time, is appropriateness, a quality of for appropriateness of clinical care. And how does this happen? It is through utilization review. So utilization of the services have to be reviewed. Now, what is that and how do you get started? It could be for both discharged patients and an active patient, where review of length of stay is done, review of investigations are done, review of their pharmacy and pharmaceutical therapy is done, and review of appropriate care, clinical care, whether it is both medical or surgical, is always done. And it could be randomly, these files could be approached, and or active patients can be reviewed. So this is something new which got added, because there is a lot of things which was happening through for the non-clinical patient or facility safety, but it is just much more than facility safety, the clinical care. And that's how in the 6th edition, clinicians involvement, their engagement, and their roles and responsibility have been also highlighted, so that it becomes more participative. So when you start a utilization review, if you're looking at lab poly, whether is there what procedure is done post-op care of 4 hours, 1 day of HDU or a post-op care, and then shifting them the patients to the ward for a day. And once the drains are removed, the patient can be discharged. The investigation which is required is for pre-anesthesia clearance, and it would be just the basic investigations. The care which is the pharmacy which is prescribed is antibiotic prophylaxis, and just in case if there is a pain during this procedure or any other comorbidity. And the procedure which is done during this process is minimal invasive or open or robotic, and whether it is appropriately done or not done, or if there has been any complication. And that is how utilization review should take place. This is a new standard, but needs to be sort of adhered to. Next slide. So other than this, quality improvement program needs to be sort of comprehensive and QA process with improvement in process efficiency in whatever we do, whether the patients move towards the diagnostic services, whether they move for any medication management, whether they move for any of the emergency treatment followed by critical care, that all remains almost same. But then quality improvement should be there both for clinical and non-clinical areas. Now, with respect to the key indicators in PSQ3, which is important, is now sample size would remain. There is a table which has always been given. So there is a universe which is there. If the universe is 500 patients for you, then the sample size can easily be created, or we'll have to follow the same sample size table for any of the purposes, including utilization review. Now for clinical indicators and managerial indicators, PSQ3, next, where we follow a Donabedian's model of structure, process, and outcome. And this would also, there needs to be an adherence to quality tool application along with managerial and statistical tool. Next slide. So Donabedian model is structure, process, and outcome. Man, money, material is structure. Processes is from evaluation to documentation to counseling. And outcome is whether there is a key intervention which has been done, or there is a knowledge improvement, or there is a satisfaction improvement. Based on that, the indicator on the priority basis can be identified. It could be taken from basically NABH standards, which was there in 4th and 5th edition, and 4th edition had 70 clinical indicators. The 5th edition had 32 clinical managerial indicators, and it could be adopted from there. Other than that, you can also feel free to put in whether it is ambulance care, whether it is crash cart, defib for structure, any of the processes within the cath lab procedure or interventional radiology, and any of the outcomes which would look at whether it is the patient's experience, or looking at length of stays and clinical care delivery process. Next slide. So these indicators needs to be monitored, and again, the quality control programs needs to be sort of put in place. It could be for any diagnostic purposes, for medication management, blood component, and surgical services, anesthesia, morbidity, and mortality. So some of the processes, some of the indicators remains the same, whether it is anesthesia related adverse events, or it is some of the adverse effects with regional anesthesias, looking at morbidity, mortalities, surgical safety procedures, and the length of stays, and the injury from any of the surgical procedures, or blood and blood component use. Looking at the donor appropriate screening, pre-op serology, you could pick and choose any which would make a lot of sense based on the data which you have in the hospital. Right now, a lot of clinical indicators are cut, copy, and paste from other hospitals. It would be ideal, which is also good, but it would be ideal if you have a problem, you realize your data. Based on that, you understand what could be a good indicator from structure, process, and outcome. Next slide. So these are limited to clinical and subspecialties, which has been which got added today. So I'll try and finish the PSQ chapter, and then we'll take up some of these indicators. So those clinical 18 indicators, 14 of them are mandatory, 4 are optional, which got added this time. Again, I would like to repeat that there has been an intent where clinical care, clinicians engagement, clinical governance, and the framework Along with recording of these indicators are the bar has been raised in the 6th edition. So those would also be covered at the end of my talk of PSQ chapter. So some of these indicators are mandatory and some of it, and you can pick and choose much more than what is already been mentioned if you want to improve the quality care across the hospital. Next slide. So the references is basically the same. You in the book which you will get, the 6th edition book, you will have all the abbreviations. What are the changes between 5th and 6th edition? More or less the standard objective elements and interpretation. The framework remains the same. You will also have a glossary. You will also get a book on annexures where a good guidance note for some of these major processes which has not been understood well, like medication management, clinical audit, understanding antibiotic stewardship would also be mentioned. And at the end, there will be glossary with these indicators which has been highlighted. So these indicators would also have what is the definition of this indicator, because it should be standardized across the hospital. The door to needle time cannot be understood differently in different hospitals. There needs to be a numerator and a denominator, and either it would be multiplied by 100 or 1000 as per the published literature and a validated tool. It could be expressed in percentages. It would the frequency would also be mentioned, and whether it is mandatory and optional, and if there are any additional guidance note as a remark would also be there. So that is at the end of the book which you would get. Next slide. So other than that, we covered patient safety, we covered quality improvement, we covered the quality indicator, structure, processes, and outcome. Now there are tools which are available. It could be very, very simple, and throughout the assessment, what we have been seeing is all these tools have not been understood and realized or been implemented in a good intent. It has been just done for doing sake, like root cause analysis, a 5-why analysis, and drawing a tree diagram for root cause analysis is extremely important. Similarly, doing a brainstorming and then doing a fishbone is very, very critical. Similarly, there needs to be a good a procedure diagram as per the ISO 4.2.1, where the processes are completely detailed out with respect to the start and the end of the process, and whether there is the task and the decision which is governed. Based on that, we can do a lean management, whether it is value add or a non-value add. Similarly, Six Sigma, DMAC principles, or BCG matrix, Taos matrix, spaghetti diagram, six hats diagram, or mind gaps. So there are many such tools which needs to be also used appropriately, and that is where we see lots of problem, because these tools, whether it is a decision making tool or a program implementation tool or any of the data analysis tool, it all ends up into RCA, kappa, and drawing fishbone, which is inappropriate. So just like good algorithm, there is a quality tool algorithm, and it cannot everywhere RCA cannot be fitted in. So if you want to analyze a program, a PDCA needs to be done. So next slide. That is where appropriate quality improvement tool is something which is which is important, and that is how the assessor would also look at this particular thing. Now, this is a new objective element which got initiated. Now, there are lots of quality improvement, but we don't know what is an improvement, because we have only sort of you looked at critical biomedical equipment downtime, and then you have drawn a fishbone, and we don't know whether that fishbone has any value. Now, the value would come if there is an impact on cost, an impact on efficiency. So if you've done a lean management and you have removed all non-value added exercises, now your efficiency for OPD waiting time is only value add exercise, then the cost of implementation or the cost of the process should improve, and the inefficiency, the flap within the system should also, so even if you have reduced 10 seconds in the procedure, 30 seconds, 2 minutes, that efficiency should be also recorded. So that is where just doing or implementing or drawing a diagram will not help. So, and this is the new tool, new objective element which got added. So please look at patient safety, cost effectiveness, whether it is a patient-centered approach, whether you improve the timeline, any of the efficiencies where input and output were measured, and with this, either the equity in the healthcare got better. Next slide. So there were earlier in the 5th edition, it was mentioned that quality improvement tool or at quality activities would undertake some projects. There would be analytical tool, there would be a statistical tool, and there would be managerial tool. So that was for A, B, C, and D. Now C, D, and E, they have all been merged into 4C, which is basically looking at appropriate analytical, statistical, and managerial tool, because it was not making sense, and every time any of the tool would just the assessor would also pass it through. So here it has been sort of clubbed depending on the, but then cost and efficiency is the new thing which got added. So depending on the project, you have to identify an appropriate tool. I'm again saying appropriate is the buzzword here as a tool. Everything cannot be RCA and fishbone. Root cause, run charts, normalizations, Pareto, or spaghetti, all of it would be, there are appropriateness, warranted, quality tool should be applied wherever it needs to be applied, just like a good management. So strategic management tool is for strategy and decision making. It cannot come into any of the process analysis tool. So please look at that, and that would be extremely important. Next slide. So now, depending on the projects, you apply a good tool, which is a quality tool. Now, statistically, your sample size, which comes with respect to that table, which is uniform across for any scientific literature, and then you need to also look at sampling mechanism. And a good sampling mechanism is a standard randomized sampling, or it could be stratified sampling. So that should be sort of good enough. Doing a control chart or ANOVA mechanism would be important. Just like for a sample size, if your universe is 5,000, your sample size would be 357. If your universe is 10,000, your sample size would be 370, and that would define the statistical tool. Now, the managerial tool, again, it would be PDSA, force field analysis, affinity diagram, because when you're drawing, it should be a tree diagram. RCA cannot be just one bit of a blood transfusion error. There could be multiple reasons, and multiple RCA should be done, and that's the affinity, and that's the tree diagram which we need to process. Similarly, matrix and super urgent, super important, TAUs, BCG, and SWOT should be done. Next slide. So this particular standard where PROM, there were two things, PROM and PREM. PREM has been taken within the PRE chapter, and PROM comes as a representation. It was an excellence. It is very important because surgeon-based success rates are no longer valuable. Each patients have to be followed at the time of discharge as 3 months, 6 months, and a year. And a qualitative assessment tool. It could be EQ5D5L, it could be WHO's, COO's, it could be various qualitative tools for each syndromic or systematic or disease process needs to be also followed, and that is what PROM would be, and that has been moved from excellence to achievement. This is one of the areas where we see a non-validated tool being used and not being practiced in its complete intent. Next slide. So now we'll quickly move to patient safety and quality improvement, which needs to have its top management support. So there needs to be a managerial and clinical governance framework, and whatever you do needs to also have the management's approval. Next slide. So PROM and PREM, whether it needs to be done annually, it could be just an annual exercise. It could be you could look at CABGs, you could look at COPDs, you could look at critical care, you could look at TKR, THRs, you can look at PTCAs, you can look at mental illness, paranoids, schizophrenias. So there are multiple order sets which are already available as for PROM, and it could be you could select what is an area of expertise. It would be good if every department has one PROM, just like a clinical audit. Now, what is important is that what was mentioned in the 5th edition is that the management makes adequate resources available for QIP and earmarks fund. So that has been sort of clubbed into one, because resources and funding goes hand in hand. So appropriate fund allocation should be there for quality improvement exercises, whether it is training, capacity building, application of the tool, man, money, material, because you need to have manpower to collect some of these data and do analytic analysis. So if no data is available, then organization could make a beginning with earmarking some of this tool, and that is how that would be a good start, and we'll look at the management support or a leadership support. Next slide. So management makes available all these resources which is available, which needs to be there, and whether appropriate environment, measurement, and methods are also supplied to the support services or to the quality management team. Next slide. So incident report again is very critical, and that is important to ensure continual quality improvement. And those 3 words are very, very critical. It is a patient safety and quality improvement chapter, where it needs to be a continual improvement. It cannot be a very fragmented or point prevalence thing. It needs to be longitudinal follow-up with all appropriate data, all clinical indicators, all incidents, all quality tool applications, all improvement in cost efficiency and efficacy, both for clinical and for managerial, needs to be followed. Next slide. So I'll not get into the detail of incident, because that is, I think, every hospital has become extremely mature, and that is sort of automatically happening. Those incident are being captured, whether it is identification, reporting, review, or any action on those items. Incidents could just not be clinical, it could be also managerial. So those are captured, but what is important is it has been, again, it was there in excellence, and it has been moved to commitment. So the incidents get recorded. What a good institution would do preventive work and would also track near misses, adverse event, and sentinel event. So if you are also extremely alert and honest with an integrated approach, track near misses, that institution definitely has quality culture in place. Every institution boasts of good quality culture, and NABH has not been done for certificate purpose to hang it on the wall. Every hospital says that, but then there are few quick indicators and where we can assess the quality culture, and near miss and sentinel event recording with its honesty and integrity is one of those indicators. Next. So I will then quickly move on to the KPIs, the key performing indicators. But within this, till the slides come over, the clinical audit is again one thing which has not been adhered to and has been a complete miss. And that is where I think it is important that all of us needs to engage with the clinicians and look at the problem. So most of the time, it is the same old either infection or antibiotic related clinical audit which is being done. And I think we should get mature enough now to move away from, because that has already been captured in the chapter 5, surgical prophylaxis, clinical audit, or clinical audit for surgical site infection, or CLABSI, COTI, or hospital acquired pneumonias, or ventilator associated pneumonias, or bacteremias, or sepsis. I think it would be important that every department takes up a clinical care, whether it is, are you maintaining a good hemodialysis care, or an endoscopy care, or an EBUS care, and that one, there should be a problem identification for a good topic. There is a good clinical evidence which is available, but then within your care you have identified the data and you understand there is a quality problem, and those topics should be only taken as clinical audit, not door to needle time every time, or SSIs, CLAPSIs, COTIs, because I think we need to be mature enough to get into create one good quality culture, raise the bar so that everybody also participates. But one clinical audit per year is what would be also essential. It could be looking at application of any of the technologies, looking at length of stays, looking at clinical care outcomes with respect to disease parameters, and there could be many such quality improvement exercise. So other than that, we'll quickly go towards KPI. I would also like to mention that uh, within the active and the discharge file, or associated for or associated clinical care, like I was doing an assessment for a particular hospital in an orthopedics ward, and there was intramedullary nailing which took place, and the patient was, and I asked why intramedullary nailing was done for a big bone fracture, and that's the best process. And the first drug which was given was meropenem. I asked why. They had no good reason, because they have been given meropenem and all the patients have gone well. Second drug was piperacillin tazobactam. I asked why. Basically, they are not happy with 1 gram negative. They want to give 2 gram negative to make it more efficient. The third drug was injection tramadol. I asked them why. They said that it's a long duration surgery and the patient would have pain. I asked the patient, "Do you have pain?" The patient said no. The fourth drug was injection ondansetron. I asked why, because they say that whenever you give tramadol, ondansetron is always given. I asked the patient, "Does he have nausea?" The patient said no. Fifth drug was injection 3 points of normal saline. A decade back, normal saline has been declared as an abnormal composition. 3 was given. I asked why. They said that basically everybody who gets admitted does get an intravascular fluid. And sixth drug was injection MVI. I asked why, because the patient demands for some yellow colored fluid where they feel extremely powerful. And that is where I think our clinical audit should emerge of these practices, rather than always cut, copying and pasting what the other hospitals are doing. So with that, I'll quickly go to KPI. Next slide. So time for initial assessment was there earlier, and it remains the same. The numerator remains the same, number time taken divided by number of admissions which are there. Next. So sampling, so most of these would remain the same. What is written is the sampling is required, which has to be random, stratified or random sampling, and which should basically either come from HIS, EMR, those who have it, or should be manually recorded. Next. So it's the same which I mentioned, but denominator should include all admissions except daycare. So emergency, daycare admissions, dialysis should not be covered under as a denominator to total admission. Next slide. So reporting errors. Now again here, many a times it is just limited to lab. It is for diagnostics. It should cover both lab as well as imaging. So number of reporting errors in all modalities. So it could be CT, MR, sonography, fluoroscopy. It could be biochemistry, hemat, histopathology, cytopathology, molecular. Next. Rest of the things remains the same. You can either get it from HIS or EMR, or you can do it manually. Next. Next. So adherence of the safety precautions, you need to go and do an audit both in diagnostics lab as well as in imaging. which it should also include now nuclear medicine and radiation oncology if you have it within the scope, whether those TLD badges and the protective and equipments which have been worn at each location, which should also include endoscopy, bronchoscopy, ERCPs, EBUS, and operation theater, including cath lab. So number of staff adhering to those safety precautions, it is just not limited to biochemistry lab, and that is what we generally see that is being done, and that has been presented. So according to the scope, it should be adequately covered, and it is for the full institution. Next slide. So again, here the sampling remains the same. It should be random sampling. Sampling size would be similar to what has been given in the table. It would be possibly your last page in your guidance book. Next slide. Next. So medication error, again, it is extremely important. It is not adverse drug event or adverse drug reaction. There are 9 kinds of medication errors. It could be transcription, it could be administration, it could be prescription, it could be dilution, and those needs to be sort of appropriately recorded. And it would be total number of medication error and number of opportunities. Number of opportunities is tough, but then that is how it should be always captured. It is also important that NCC MERP index of categorization should always be taken as a reference, and that would be category A, like circumstances of event that have the capacity to cause an error. Category B would be an error occurred when the error did not reach the patient. Category C, an error occurred that reached the patient but did not cause harm. So similarly, there is from category A to I, and divided into 4: no error, no harm, harm, and death. So the National Coordinating Council for Medication Error Reporting and Prevention index is what needs to be taken as a reference, and it should be standardized across all institutions. Next slide. This remains the same. Next. So adverse drug reaction, it's completely different from medication error, and this would be part of your pharmacovigilance work. So like if you are a medical college, it is mandatory, but it would be ideal to get linked or network with your local pharmacovigilance. Every state and most of the districts has a pharmacovigilance network site, and it would be good to network with them and understand the causality analysis, which would be very, very helpful to basically improve. If you don't do it, it would be just a document, a quantitative aggregate data, which has no meaning because you don't know what the CDSO or DCGI is coming up with this analysis with pharmacovigilance and shared with you. So adverse drug reactions divided by number of inpatients into 100 and percentage. Next slide. So unplanned return to operation theater is extremely important. It could be because of staged operation, but looking at unplanned, not looking at anything which is re-exploration, not looking at anything which is staged operation. I'm sorry, I said that. So anything which is re-exploration within the same admission, it could be because of post-operative bleeding, debridement, secondary suturing and polypectomies, or anything which has gone wrong during evaluation under anesthesia should be all covered. This is very, very critical. Divided by number of patients who underwent surgeries in the theater into 100. Next slide. So safe surgical checklist, and every hospital boasts of doing the safe surgical checklist. They are somehow managing it, but it is mostly a tick list, and it is all done as yes. The sign in, and time out should be followed appropriately. There needs to be, it could be the anesthesia technician, it could be nurse, it could be circulating nurse, it could be scrub nurse, it could be not a scrub nurse, it could be basically and a senior junior resident at the theater. Anybody could be sort of doing or initiating this whole process, and it would be appropriate to have a sign off from the nurse, from the anesthesia, and from the surgical site, surgical team. But then what the intent here again is whether surgical safety checklist, is it reducing your morbidity? Is it reducing your mortality? Is it reducing your surgical safety infection? That is how it got initiated when Atul Gawande introduced it. Every hospital boasts of surgical safety checklist being used, and it is just a document which has, till date, there has been no major improvement or outcome which has been so again creating a culture is through all these parameters would be critical. Next slide. Next. Transfusion reactions, extremely important. There is a hemovigilance, just like pharmacovigilance, which we need to sort of get networked to on a Government of India site. And there is lots of good educational material which is also available. And there is also something called as material-vigilance, where biomedical equipment adverse events are also captured, and that from the medical device policy which was released, there is lots of good information which has also come in with respect to every MNCs and the device which is there. So right now we generally say it is minor in nature, and we don't capture the blood transfusion which is chills and rigors, but both minor, moderate and major trallies and GVHTs should be also captured. The denominator is number of units transfused. Next slide. So SMR is very, very important in an ICU setting, where if you have 100 beds and if SMR is 100 beds in a Western setting with a meta-analysis which has been sort of complete randomized controlled trial and systematic reviews, it comes to 100 beds has 100 good outcomes. And if that is at 1, if it is coming at 0.8, means 80% of the beds are having a good outcome, but there are 20% where it could be sort of better, where morbidities and mortalities are higher with respect to an average benchmarked SMR ratio, which is 1. And that is where SMR is extremely important. And you could take help of Apache 2, Apache 4, SOFA, QSOFA, or any of these indicators for capturing this analysis, which could help in your predictive morbidities and mortalities. Next. So return to ICU within 48 hours, pretty easy, needs to be captured, divided the numerator. The denominator is discharges and transfers. Next. So similarly, return to emergency within 72 hours is almost similar, with the denominator being those who come to emergency. Next. So here, I think there is one correction which I would like to indicate. It is hospital-associated pressure injury rather than ulcer, and that we needs to sort of redefine. But HAPI would be, again, you could follow a Braden scale, you can follow a Waterloo scale or a Norton scale. Based on that, there needs to be a mild, moderate, severe, and surgical analysis risk, and there would be an intervention which would be required. And if you do that intervention appropriately, similarly, the length of stays would decrease, and the cost of the stay for the patient would decrease, but it would be looked at from hospital-associated pressure injuries and not ulcer. And the denominator is number of inpatient days. Next slide. So catheter-associated urinary tract infection, pretty simple, based on CDC NHSN definition. Next slide. Similarly, ventilator-associated pneumonia, here we would need to divide it into ventilator-associated event, IVAC, and possible ventilator-associated pneumonia. What we are capturing is VAP, and there could be HAP also, hospital-acquired pneumonias, but then this is what we are capturing. So we are not capturing VAE, we are not capturing IVAC, we are capturing possible ventilator-associated pneumonia divided by ventilator-associated days. Next slide. Central line associated. So this is CLABSI and not CRBSI. Those are two different things, and we see lots of different definitions which has been followed. It has been written CDC NHSN definition, which is CLABSI, which is not CRBSI, and rest of thing remains the same. And we should be very, very clear what constitutes central line, because arterial line, if that constitutes central line, we should capture it, but it doesn't. So we should be very, very clear about the central line definition. And many a times it gets missed when the assessors are looking at this indicator. Next slide. Surgical site infection, pretty simple. Next. Hand hygiene, pretty simple, based on opportunities and WHO hand hygiene audit checklist. Next slide. So surgical prophylactic antibiotic divided into three. One is right drug. Just don't know why cefazolin is not available, which is the right drug. Right now, only cefuroxime is available, which is not an appropriate drug, but just because of the antibiotic shortage, this is what we capture. So it is about the right drug, right dose, and right time and right duration. Sorry. So right drug, right time, and right duration should be given within 60 minutes of initiation of the insertion, and should be, if this is less than 4 hours of surgery, 1 dose, more than 4 hours of surgery, 3 doses, and should be also stopped. But here again, it is very critical to understand that it is not about IV to oral. So many a times they would give IV cefuroxime single dose, but then shift to Ceftum or any other oral antibiotic, which is also not right. So that's inappropriate. But surgical prophylaxis divided into three, and it should always be present as three parts of this particular indicator. Next slide. So rescheduling of surgery, pretty simple. Next slide. Issuing of the blood and blood components, looking at the time when the blood came in at the blood bank for blood grouping and cross matching, and the issuing rather than when it got sort of the call got initiated from the ward or from the critical care unit. So needs to be that sum total divided by the cross matching when it got done. Next slide. Nurse patient ratio, pretty simple, 1:1, 1:2, and floor 1:, whatever you follow, whichever indicator, 1:5, 1:6, or 1:8. So 1:6 is what generally is according to the published literature. INC only defines 1:1 and 1:2. Next slide. Waiting time for outpatient consultation, pretty simple, based on the first contact, what happens. So definition of the first contact at the outpatient should be done, divided by total number of outpatients, and every hospital could have their own mechanism and established benchmark. Next slide. So waiting time for diagnostics, both for lab as well as for imaging, should be sort of captured, and for each modality. Next slide. Time taken for discharge, one of the biggest pain point in the hospital, but divided again for cash according to the empanelments and bed type category. So it could be based on cash, TPA, and any other empanelment process. Like if you have an Ayushman, the Ayushman discharge process is very slightly different, and it would have a separate categorization. Next slide. Medical records with incomplete and improper consent. Procedure-based consent is what was written in the 5th edition, and number of discharges and death is the denominator. The completeness is what is most important. Next slide. So, number of stockouts for emergency medications. You need to define what are emergency medications, and vasopressors, and it could be for sepsis, antibiotic. It could be for the anesthesia. Those are all emergency medications which should be immediately sort of be available. Could be just insulins and number of stockouts which are there. It would be an aggregate number, or it could be, but then need to be presented by each location and each sub-classification of the drugs. Next slide. So mock drills, various disaster codes are there. It could be code blue, code white, code yellow, code red, code pink, violet, and those mock drills needs to be done, and all the variations in aggregate number needs to be captured. So incidence of the patient falls based on now definition of the patient fall is important. It's a bed fall, hospital fall, fall in the bathroom. So all of it would come as a patient fall, and those assessment according to the Mohs scale should be done, but it would be divided. The denominator would be number of inpatients days. Next. Near misses, we have already said, and divided by number of incidents which are reported. Next. Number of needle stick injuries. So it could be divided into, so anything which is sharp, classified as sharp objects, and that is what is written, and which results in exposure of blood body fluid exposure. So those needs to be captured, but the denominator is average occupied days. So there had been a lot of confusion with respect to denominator. Some of the University of Virginia is where EpiNet is the format which is generally used for blood body fluid exposure or for occupational injuries needle stick, and EpiNet form should always be used. University of Virginia is the reference code. Most of the publications is based on average occupied beds and not inpatient days, and this is where we need to have some kind of a correction, what we see during the assessment process. Next. Handovers during shift, both for the doctors as well as for the nursing staff, and that's pretty simple, but looked at from the denominator is opportunities. Next. Safe and rational prescription. So this is extremely important. There is a government movement on SRAM, safe and rational use of medication, and that is where the Drug and Therapeutic Committee, that is where the prescription audit should take place, that is where the clinical pharmacist and the clinical team needs to also participate. So rationality with respect to every process. It's just not limited to antimicrobial prescriptions, which is antibiotic, antifungal, antiparasitic, antiviral, but it is antitubercular. It is also for hypertension, for diabetes, for sepsis, for stroke management. So those rational prescriptions needs to be sort of audited and presented. And the total number, the denominator is total number of prescriptions which are audited. Now this audit can be done by anybody. It could be, but then they need to be trained, because it would be good if there is a clinical nurse practitioners or a nurse who has a clinical exposure. It could be done by clinical pharmacists, which would be ideal. Those who have Pharm D, not B Pharm, M Pharm, and those who are clinical pharmacologists, MD in pharmacology or DM in clinical pharmacology, or those who are part of the clinical care team. Next slide. So now we'll come to something which got added, and fortunately I have 10 more minutes. These are completely new, specific clinical indicators. So safe and rational prescriptions, it would be good. Let's start with inpatient services, because which is easy to monitor, but ideally it should be done both for outpatient and inpatient. So antitubercular therapy, mostly it would be outpatient, but it should be sort of done both for OP and IP. But right now, if it is new and if it is you're starting, let's look at IP. Now, for Department of Cardiology, so here basically we are looking at the beta blocker prescription, the number of patients who are discharged with a diagnosis of heart failure. But here it is very critical to understand that it is heart failure with reduced ejection fraction, and the good ejection fraction would be 40% with reduced ejection fraction. And are they being prescribed beta blocker, which is constituted, which is supposed to be a cardioprotective drug, and denominator is number of patients discharged with a diagnosis of beta blocker. So those are the first indicator which is important, and this comes from basically Heart Failure Society of America guidance note, where they say that the management of heart failure depends on 4 drugs. Either it is given as ACE or ARB indicators, or it could be given as beta blockers, or it could be mineralocorticoid receptor antagonists or SGLT inhibitors. So either one should be there, and that is how American Heart Association also classifies. So this is a good indicator, and if it gets admitted under internal medicine, it should be also taken as an internal medicine indicator. Next slide. Right, so I've already covered, this is HFSA guidance note for heart failure, and these are the drugs, and this is what we need to sort of look at, whether it is rational and whether this has been given for heart failure management, and all those who get discharged with beta blockers divided by patients who had heart failure. Next. Next. Now, this is pretty simple. I think every hospital at least attempts to capture this. Basically looking at an acute myocardial infarction, and there is a American Heart Association CHOP program, which is Cardiac Outcome Assessment Program. Based on that, if we are looking at the door to balloon time, and that is done within 90 minutes, which is the international benchmark, divided by all those patients who have acute myocardial infarction undergoing primary angioplasty. So what would be a start point? Start point is where the first ECG after an arrival got done at the hospital, and the clinicians then decide that the primary angioplasty needs to be done as the first choice of the treatment. And the end time definitely is where the device activation takes place. So if the end time and the start time is pretty defined, it would be very easy to capture. We are looking at 90 minutes, which is the international benchmark. Next slide. Next. Now, for endocrinology, why this has been added again? Because the internal medicine, the endocrinology department, cardiology, nephrology, every neurology, every department follows diabetes management in a different level and with a different style, and then also with respect to hypoglycemic episodes. Now, it is important to also look at POCT level. It could be done at point of care testing too. So the numerator is number of patients with hypoglycemic events where the target blood glucose was achieved, and number of divided by number of patients where the hypoglycemic episodes were recorded. And so it is important what exactly is these episodes. So hypoglycemic episode is not 40, but according to the American Diabetes Association, the achieved level for hypoglycemia is 54 milligram per deciliter, and what we need to sort of look at is hypoglycemic level should be at the target level is 70. So whenever it is below 54, it needs to be captured, and whenever it is at 50, what is the time taken and how many patients had these episodes needs to be captured, and that is where it is important. So this is a good start. Otherwise, diabetes management itself is so different because it is a single bolus mechanism rather than a sliding scale of insulin therapy, which needs to be sort of practiced, which you could take it as a good clinical indicator if you want to do diabetes management. Next slide. Next. So in OBS, perineal tear, so any patient who basically looks at spontaneous perineal tear, where episiotomy was done or not done. It could be primary, secondary, and tertiary care tiers, and defined as per Royal College of Obs practice, divided by total number of vaginal deliveries. This is completely avoidable, and the perineal tear definition is that it is the tear which happens in the tissues, which includes skin and muscle, and that is how the degree of difficulty of perineal tear should also be captured. Next slide. In ophthal, it is very critical to understand endophthalmitis, and we have seen many of the hospitals who basically does a lot of procedures in hospital or otherwise in an outpatient setting, and the patients have endophthalmitis leading to blindness. So post-operative endophthalmitis is an inflammatory condition, and it could be one of the infective reasons, which could be bacteria and fungi. So number of cases of post-operative endophthalmitis and divided by number of ophthalmic surgery, which needs to be sort of captured. Next. In gastroenterology, we have looked, so there's a lot of debate which happened during this whole process. We spoke to the Indian Society of Gastroenterology, we spoke to the American Society of Gastroenterology. It is a good practice to do sedation for endoscopy, ERCP, colonoscopy. It's a good practice. But then Indian Society of Gastroenterology or American Society of Gastroenterology overall have said that it is mandated for colonoscopy. It may not be mandated for upper GI endoscopy. And that is where we said that either a minimal sedation or a deep short general anesthesia, which would be required for colonoscopy. And that is where what we need to capture. And it would be good if it is also done in a short GI or a sedation is done as a good practice for an upper GI. Next slide. Next. So lap chole is one of the most common surgeries, and we also see bile duct injury is one of the most common complications which happens post lap chole done, and that is what we need to sort of also capture. Number of cases with this injury divided by number of lap choles performed, which is pretty simple. Next. In biochemistry, number of point of care tests, because we see there are for electrolytes, for ABG, for cardiac enzymes, there are for blood glucose, there are lots of point of care tests which are available. So percentage of number of patients with POCT where clinical interventions was indicated, because if there is a hypoglycemic episode or there is a hypokalemia or hypochloremia through a point of care test, and we need to sort of act on it. So because it generally would not come, all these critical reports may not come from the central lab. So that needs to be captured, and those clinical interventions needs to be documented. Next slide. Rehabilitation, one of the support services which covers almost cardiac, pulmonary, neuro, renal, all kinds of orthopedics, all kinds of pediatrics, obs and gynae. Rehab is extremely critical, and that is where the functional gain is what needs to be sort of captured with the rehab. So what is important is to understand that the functional independence measure scale is available, which assesses the physical and the cognitive disability. It ranges from 18 to 126, and higher scores is rehabilitative wise better, and that is what we need to sort of capture. Right now, it has been restricted to neuro rehab. If you want to sort of have a good quality systems in place, it could be done for all departments. Next. So sepsis management, there is a surviving sepsis campaign with looking at 3 hours and 6 hours bundle, which also got changed into 1 hour sepsis bundle. But it is just not about giving in antibiotic. It is also giving in an adequate number of vasopressors and intravascular therapy. So 1 hour bundle would basically look at administration of antibiotics, which is broad spectrum, looking at rapid administration of appropriate fluids, looking at applying of vasopressors, and all of it. There are 4 or 5 components. All of it would be 1 hour sepsis bundle. And if you have labeled him as query sepsis, this all needs to be done and done on time. And that is what needs to be captured. It could be at ER, at critical care, whenever, howsoever you want to do it at your institution. Next slide. So respiratory COPD, this is a gold standard, a global obstructive lung disease standard, where basically looking at COPD patients who has a COPD action plan. Now, COPD action plan basically is according to the gold standards, looking at giving a beta agonist, giving of steroidal therapy, and which is these are appropriate therapy. Antibiotic may not be indicated at this point of time, but also looking at appropriate medications, preventive counseling, that is cessation of smoking, and vaccinations, that is pneumococcal vaccine being prescribed. So that is what would be a COPD action plan. So cessation of smoking, adult vaccination, the pneumococcal vaccine, and appropriate treatment would be covered under this action plan. Next slide. In neurology, it is door to needle time with respect to stroke. I think most of the hospitals would be basically measuring it, and it is important. We right now there has been a lot of debate when we introduced it. We actually 4.5 hours is what the intervention would look like. Doing an appropriate CT or a mixed CT-MR. Dividing this into thrombolysis, alteplase, or thrombectomy. We are not looking at that because we have no control of the community patients coming it on time. So 4.5 hours has not been sort of included in this particular indicator. What we are looking at, whenever they come in, the door to needle time of 60 minutes have been achieved for all those patients who have been identified as stroke, and thrombolysis has been introduced. So it could start from the patients when they have been diagnosed as stroke. That could be a good starting point, and whether alteplase or the similar drug has been instituted or administered. Next slide. So there is a patient group called bronchiolitis, and bronchiolitis patients should not be given antibiotics, should not be given steroids, should not be given any of the nebulization, there need not be a diagnostic analysis, chest X-ray, which needs to be done. This is as per the American Association of Pediatrics, which Indian Academy of Pediatrics also have adopted. But unfortunately, all of it gets done. And that is where it is, this indicator has been captured because it's viral in nature. Number of patients treated inappropriately of those who had bronchiolitis based on denominator of total number of bronchiolitis which comes to your hospital. Next slide. Now, for oncology, there has been a lot of debate with respect to medical oncology, liquid malignancies, bone marrow transplants, radiation oncology, and surgical oncology. But as a start, since there was a clinical indicator, and what has been followed also in Australian and Canadian accreditation board, a multidisciplinary treatment of all cancers. I'm again stressing all cancers. Coming to the multidisciplinary board is important. It is just not about oncology, but also general medicine, obs and gynae, breast, urology. All cancer should come through a board which is called as multidisciplinary tumor board, and that which needs to be captured. And here the standardized protocol needs to be sort of adhered. Next slide. In nuclear medicines, this could be optional, but it is important that we are not looking at radio iodine, because the world has gone far more than iodine based therapy. We're looking at radiopharmaceuticals, and any of the adverse reactions, nausea, dyspnea, bronchospasm, which is recorded, But then there is iridium, there is technetium, there is thallium, there is a lot of radiopharmaceuticals which are available. All needs to be captured. It could be optional if the department, if the institution doesn't have that within the scope. Next slide. In radiology, again, a lot of it was already there as an indicator in the 4th and 5th edition. So intravenous contrast media extravasation, it could be there for CT, for fluoroscopy, for MR, and if there is an extravasation divided on the patients who have been given contrast, which is pretty easy, self-explanatory. Next. At ER, again, there could be many things at the ER. It could be both time door to ECG, door to balloon, door to needle for stroke, door to all gets captured within from the ER itself. But for the Department of Emergency Medicine, time taken to triage was something which gets followed internationally. And that would be, again, triaging process is very, very critical. It's not the patient coming in and starting with the treatment, but appropriate distinction of red, yellow, and green based on clinical criteria. As soon as you established, and what is the time taken to triage these patients appropriately at emergency medicine is what is getting captured here. Next slide. So this is the last clinical indicator, which is dialysis, which is very, very common and in use. Not looking at anything with respect to post hemodialysis or hyperfusion dialysis, what is the drop in the creatinine level, but it is looking at achieved target hemoglobin. So the number of patients undergoing dialysis who are able to achieve target hemoglobin level is what is measured, and what is actually, according to the American Nephrology Association, is looking at hemoglobin level of 11 or 12 gram per deciliter. So that is what needs to be achieved even when the patient is on dialysis, and the drop should not happen on patients on maintenance hemodialysis. Next slide. So that is it from our side with respect to key performance indicators, and fantastic. I'm able to close it on time, and so we have covered patient safety, PSQ. We have covered all the indicators. A new objective element was utilization review, and new indicators was 18 clinical indicators which got initiated, and hope this is of value to all of you. Wish you all the very best, and I would like to pass on to my close friend and colleague, Dr. Rajiv, who is going to take charge of the chapter called Responsibility of Management.
Thank you very much, sir, for this informative session. I would now request Dr. Monica Gupta to please take over and start with the chapter on responsibility of management. We will try to take all the questions that the participants have asked as soon as we get the time again. Thank you very much.
Afternoon. I'm covering for Dr. Rajiv Kumar. He was supposed to take the session, but he couldn't because of an emergency, and therefore I'm taking the session for you. Well, so responsibilities of management. Well, as far as this is a chapter which has one new standard, and therefore we now have, instead of the initial I think 5 standards, we now have 6 standards, if I'm right. Just 1 second. Yeah. Okay, so that is the major change. And yeah, so earlier we had 5, we now have 6, and that is the major change. Beyond that, I'm sure you've realized, and I mean, this PSQ chapter, of course, is the scariest for anybody who's trying to implement, because now we know that we have to get the clinicians engaged no matter what, right? So that was a very fantastic presentation by Dr. Sanjeev Singh. I myself enjoyed it thoroughly. So now the message is clear. Let us say almost 20 years down, as far as NABH is concerned, and if you look at the standards themselves, the first 5 chapters are patient-centered chapters. right? So almost 2/3 of the objective elements are a part of the patient-centered chapters, and therefore the message is clear that we now need clinician, very active clinician engagement in the implementation of NABH standards. And while quality managers, etc., will get the implementation started, it would be difficult to maintain and proceed with accreditation and maintenance of NABH standards without clinician engagement. So those were the KPIs, and the same message is there for ROM. So let's look at what ROM has. So the first one is about the organization identifies those responsible for governance, and their roles are identified. Can we go to the next slide? So in this, what has been done is the first objective element is a core objective element, where we want to identify those who are responsible for governance and their roles and responsibilities, which should also be documented. So in this, what has been added is that the structure of the hospital's governing body or entity is described in a written document. So basically, we're talking about the organogram, and also the document describes when and how the authority of the governing entity can be delegated and to whom. So this has to be added to the document, wherein you have to define the roles and responsibilities, the governance structure, and also the delegations. Next, please. So if the content otherwise remains the same as far as terms of reference, bylaws, etc., whatever is expected. Next, please. In 1B, we've talked about those the vision, mission, and values being laid down by the organization's governing body, or those who are responsible for governance. So the interpretation of 2A has been added to 1B because they were kind of similar, and we reduced an objective element there. Next slide, please. So we look at what has been added. So the vision, mission, and values of the organization shall be displayed prominently. Earlier, this was 2A. Only a display on its website would not be appropriate. The same could be translated and displayed in the local language also. Next, please. 1D has been changed from achievement to commitment. So those responsible for governance monitor and measure the performance of the organization against the stated mission. Right, so this and here in the interpretation we've also added this shall include quality and patient safety parameters, which should be monitored by the governing entity, right? So it was felt that because this really doesn't need if the governing body is engaged and needs to be aware of whatever is happening, it also needs to monitor the performance. It should be at the commitment level rather than achievement. Next, please. Those responsible for governance support safety initiatives, clinical governance framework, and quality improvement plans. So here again, the point that I was making right at the beginning, the clinical governance framework has been brought into the standards, which was not there earlier. And we've also added to the interpretation of 1F that to the sentence, the information shared shall include the salient points of risk management, process of reporting risk, sentinel events, and quality improvement activities. So that has been added, right, to this to the interpretation about supporting the quality initiatives, clinical governance framework, and quality improvement plans. Next, please. And for 1G is a new objective element, where we've talked about the development of the clinical governance framework as to how it should be developed. And what do we mean by clinical governance framework? So clinical governance framework shall consist of patient safety, medication safety, clinical audits, clinical pathways, clinical indicators, education, and research. Leaders of clinical departments shall select and implement clinical practice guidelines, care pathways, and/or clinical protocols to guide clinical care. The departmental leaders shall encourage clinical audits, education, and research. Right? So that is what would be constituted by the clinical governance framework. Essentially, whatever it has a clinical bearing in the standards, so patient safety, medication safety, clinical audits, pathways, indicators, education and research. And the departmental leaders, clinical departmental leaders would be expected to take part in implementation, selection and implementation of clinical guidelines, care pathways and clinical protocols to guide clinical care. So this objective element calls for greater participation of the leaders of clinical departments, who will also encourage clinical audits, education and research. Right. So it's actually very nice that Dr. Sanjeev Singh could explain in so much of detail whatever the indicators are required, and a lot of, I would like you to know that complete almost one whole day was spent by the technical committee on site for developing the indicators. Right. So a lot of effort has gone into it, and in fact these are the bare minimum. They were far more complicated indicators which other accreditation agencies are using, and it was felt that as a starting point, let us just limit ourselves to these. There are far more many, but it would be challenging for organizations to implement them. Right. Let's go to the next slide. Those responsible for governance support the ethical management framework of the organization. This includes so this is an achievement level objective element where we have also recommended that this should be done in a defined time frame. Whenever there is an ethical issue, it should get addressed within a defined time frame. Next, please. Then those responsible for governance inform the public of the quality and performance of services. Now, this is something actually which has a regulatory bearing in many countries, most of the developed countries abroad, right? So we felt that it really doesn't need to be at excellence. Anyways, NABH expects accredited organizations to submit their indicator data to them. So it should, why should the patients being the central stakeholder, why should they not be informed about these indicators? So it has been on a regular basis, and it has been brought down from excellence to commitment. Next, please. Those responsible for governance manage the organization in an ethical manner. Can we look at the changes? So let's go to the next slide. So the objective element ROM2B, the ethical management framework, includes processes for managing issues with ethical implications, dilemmas, and concerns. This has been changed from excellence to commitment. Because simply put, ethics, all of us as doctors, as medical personnel, are bound by a code of medical ethics. It is fundamental to our existence. And so it makes sense to have it at the commitment level. Next, please. Next slide, Rohit. Yeah. Now, the 2C, the organization discloses its ownership. So earlier we had only mentioned a registration certificate. Now we've added what all can be, because many quality managers find it difficult to figure out, what applies as far as the ownership is concerned. So examples and what are the, what are the entities under which the hospital is governed have been included in the interpretation. Hospitals are governed under the provisions of Companies Act, Charitable Trust Act, Societies Registration Act, Limited Liability Partnership Act, Sole Proprietorship, and Government of India or state government. The ownership of the hospital shall be disclosed accordingly. The disclosure could be in the form of a registration certificate. So this should make it easier for people to understand as to what is expected for this objective element. Next. So ROM3 is the new objective element. And at this juncture, I would actually like to tell you that, in fact, NABH itself has released a guidebook on climate action and sustainability in healthcare. You can download it from the website. At the end of this session, I will put the link in the chat box. Right. So those responsible for governance ensure sustainability in hospitals by addressing environmental, social, and economic factors from long-term well-being of healthcare system and community, right? So this being a new standard, we'll discuss all the objective elements. This is the major change in this chapter. So ROM 3A is those responsible for governance address the organization's sustainability program in terms of environmental, social, and governance responsibility. So social responsibility was already there. Now we're discussing also the environmental and also governance, ESG initiatives. And let me tell you, this aligns us with the global requirements, ISCOA requirements, and also the WHO itself has released the Sustainable Development Goals. And there is also a One Health concept which is now coming up globally, which is accepted and which is coming up globally. So this objective, this standard and this objective element aligns it with global trends and going in way. I mean, the fact that the life of an average citizen is affected by climate, etc., and healthcare has its own responsibility. So therefore, this standard makes tremendous sense, right? So the interpretation for the objective element is that environmental sustainability includes energy usage and efficiency, climate change strategy, waste reduction, biodiversity loss, greenhouse gas emissions, and carbon footprint reduction. So in all of these, the hospitals have a role to play, and this should be incorporated, and this should be addressed by the program. Next, please. Social sustainability includes fair pay and living wages. So we've tried to describe what each of these are. So social sustainability includes fair pay and living wages, equal employment, opportunity, employee benefits, workplace health and safety, community engagement, responsible supply chain partnerships, adhering to labor laws. Governance sustainability includes corporate governance, risk management, compliance, ethical business standards, avoiding conflicts of interest, accounting integrity, and transparency. Right? So it should be clear to everybody, like at least as a starting point, these are the expectations. Next, please. The organization takes initiatives towards an energy efficient and environmental friendly hospital. So this was there earlier also, and it has from FMS 2G, it has been shifted to ROM 3B because it fits in with this standard. Next, please. Those responsible for governance address the organization's social responsibility. So the Board of Governance and leaders shall develop social responsibility policy and implement it. Free camps, outreach programs for below poverty line population are some of the examples. At a minimum, all regulatory requirements like corporate social responsibility shall be met. Next, please. Staff well-being is promoted. So HRM 9A has basically been shifted to ROM 3D because it fits in better over here. Next, please. So this is an excellence level objective element. The organization follows sustainable procurement practices. So these involve sourcing products and services that have a lower environmental impact. Hospitals can work with suppliers to prioritize environmental friendly and socially responsible products, right? So the supply chain, how it is managed, should have eco-friendly materials, etc., etc., right? And there are ways of doing it. When you talk to the vendor, you will be able to figure out, right? Thank you. Can we move to the next slide? This is 3F. Hospitals shall encourage employees to use common public transportation to reduce the environmental impact of commuting and carbon footprint. So that is a new objective element. The hospital shall encourage employees for carpooling, cycling, and wherever possible use of public transport to reduce environmental impact. Efficient environmental friendly logistics and transportation management within the hospital can also contribute to sustainability. So that's easy to understand, but it expects that the employees also participate in reducing the carbon footprint. Next, please. So this is achievement level objective element. Next. Rohit, next, please. Rohit, can I have the next slide, please? Yeah. The organization, yeah, go back, please. Sorry. Yeah, the organization ensures financial sustainability of the hospital by balancing the financial aspects of healthcare delivery Balancing the financial aspects of healthcare delivery is crucial for long-term sustainability. This involves efficient resource allocation, cost management, and revenue generation strategies. Right. So this makes sense. And Rohit, why have you stopped sharing? Yeah. Okay. Next. Okay. Now coming to ROM4, the organization is headed by a leader who shall be responsible for operating the organization on a day-to-day basis. So here again, clinician participation and clinician leadership is emphasized in whatever changes that are there. By and large, that is the main change. Can we look at the next slide? So person handling the organization has requisite and appropriate administrative qualifications and experience. So ROM 3A and B have been merged and taken to as 4A. Appropriate, because remember that now subsequent, if we are interested in numbers, so because one new standard has been inserted, right? So the subsequent standards have to be renamed, have had to be renamed, right? So what was 3A has become 4A, and then 3A and B have been merged. So appropriate qualification implies qualification in hospital management and administration, and appropriate experience implies administrative experience in a hospital. Next slide, please. 4C, the leader appoints or participates in the recruitment of senior leadership of the organization who will assist in the day-to-day functioning of the organization. And this includes at least the next rung of the organogram. Next. Each departmental or service leader shall document the services to be provided by the department and have an integrated approach to align these with the services of other departments. So what is emphasized is, one is, while we've said in AAC that each department services will be defined, now it is categorically stated it is the departmental leader's responsibility to define the services and also have a multidisciplinary approach, which was highlighted both in AAC as well as in COP. So the leaders participate in patient safety and quality improvement activities based on institutional priorities. So the leaders, departmental leaders, also have to align themselves with the institutional priorities and contribute towards the quality improvement activities. Next, please. The leader ensures that each organizational program, service, site, department has effective leadership. So this is actually quite, if we have leaders, they have to be effective, right? So this has been brought down from excellence to achievement. Right. Next, please. Then coming to professionalism in the functioning of an organization, let's look at the changes quickly. The organization coordinates the functioning with departments and external agencies and monitors the progress in achieving the defined goals and objectives. This has been changed from achievement to commitment, because again, like we said, multidisciplinary approach along with how they collaborate with external agencies and in the progress of achieving defined goals and objectives, which is something which is anyways, all these reviews have to be done on a regular basis, right? So it's been brought down from achievement to commitment. Next, please. Next slide, please. ROM 5F, systems and processes are in place for change management. So a sentence has been added here. Organization has a written guidance in place for change management, right? So that has been added. Next, please. Leadership ensures that patient safety aspects and risk management issues are an integral part of patient care and hospital management. So the change here is we've added leadership to the standard itself, right, rather than organization. Next slide, please. Next, please. Yeah. So leadership has been added throughout, and in 6D, the interpretation of FMS 7E has been added. So the objective element is leadership ensures implementation of systems for internal and external reporting of system and process failures. So earlier, this objective element was a part of FMS, where we expected the hospital to report all the system related failures and also including MVPI, etc. So that interpretation has been brought over here as a part of this objective element, right? So the organization has a system in place for internal and external reporting of system and process failures. The contingency plan there should be a contingency plan in place to deal with the situation of system and process failure anticipated within the organization. Next, please. Next slide, please. I think we are facing a lag, so it's taking slide transition is taking a bit of time. Please bear with us. And this is in case of MRI machine. I mean, examples were cited in that if there is an MRI machine of the breaking down, internal reporting has to be done. If there's a radiation source related issue, it has to be reported to AERB. In case of fire, strong internal and external reportings are required, and the system for reporting shall be documented. Next slide, please. Next slide, please. Okay, now the plan includes a mechanism. So this is what has been brought in from FMS about a service continuity plan. The plan includes a mechanism for maintaining service continuity of the organization's critical operations. This plan shall help the organization to improve its ability to respond when such incidents occur. The plan shall ensure that critical systems and services do not fail or that failures are recovered within minimum time frames. The plan shall be tested at regular intervals. Right? So the service continuity component as to what is expected has been brought in here because in order to remove redundancy and have continuity of the interpretation and the objective element. Next slide, please. Okay, so that finishes ROM. I have to share two links in the chat box. One was, wait a sec. Yeah.
Thank you very much, ma'am, for taking up the session and enlightening our knowledge on the chapter of ROM.
Yeah, just one more thing, Priyanka, I wanted to clarify yesterday what I had said about, cleaning of this thing.
O2 humidifiers?
Yeah. So that what I was saying was correct. It is sodium hypochlorite. I've also pasted the link of that reference, the WHO's checklist. However, what our infection control officer also had to say was that sometimes sodium hypochlorite can damage these humidifiers, and therefore E2O, if you have it, may be preferred, or glutaraldehyde may be preferred. Right. So, and I've added the checklist here from WHO.
Okay, ma'am. Thanks a lot for sharing the resources. And definitely, we would like to mention that NABH has released the guidebook for climate action and sustainability. If you want to go in details, you can go through the guidebook. Can we take some questions, ma'am?
Yeah, sure.
Okay. Okay. They have mentioned regarding how to make annual training planner for staff. We will cover this in HRM.
Right.
Yeah, we even asked how to show the implementation of public transportation.
How to?
Show the evidence for public transportation.
You could do a survey. See, these are things which we have not prescribed, and you can have any innovative ideas. You could do a small Google survey when you're doing your employee survey, etc. Anyways, we have to take employee feedback, etc. So you'll get some ideas. You can figure out. We are not prescribing anything. We are introducing the concept for now. See, with whatever is new, right now we really cannot afford to be prescriptive. We have to allow the hospital to find what are contextual solutions and what are easy to implement. We do not want anything to be a pain for you, but these are necessary standards and objective elements.
Exactly, ma'am. Then they have a question regarding, does registration certificates needs to be displayed?
Uh, no, you have to, yeah, it should be displayed in one or two common areas, not all over the place, and maybe your website. But have we really mandated it? That we've said you have to make public your ownership. Yeah. So in your introduction on your web page, etc., you normally everybody says what is it, what is your ownership. We've not asked for
Yes.
display of registration certificates, as far as I can remember. We've said you have to make public your ownership. Right? So when we say
Exactly.
make public, you have to inform the public. You can choose the mechanism.
Okay, and one question is regarding, can you differentiate between organization leadership and governance?
Leadership would be generally when we say leadership, we start from chief executive officer downwards. And of course, but if you have a proprietorship or ownership, it will depend on the type of organization you have. And generally, when we say top management, and basically when we are talking about leadership, at least in a larger context, it is CEO downwards. Now, sometimes the proprietor himself will be the CEO, right? So basically those people who manage the day-to-day operations is what is expected, and from this and it will all depend on the organogram. And when we are talking about clinician leadership, there are obviously departmental heads, MS, etc. Some examples are given in the objective element.
Exactly, ma'am. Ma'am, since we have time, we would like, can we take some questions of PSQ chapter also? Sanjeev sir, are you there?
I hope sir is there. Yeah, he's answered a lot of them.
Yeah, he has answered a lot of them. Believe, yes, he has answered them through the comments column.
Yeah, he has answered all of them.
Okay, so let's move to the next session. Thank you very much, ma'am. Thanks for your,
Thank you so much.
thank
Over
you, ma'am.
to Binama, I think.
Yeah. Now I would like request Benama Korean ma'am to take up the chapter on FMS.
So thank you so much. Thank you very much. And all the best, everyone. Happy learning. Enjoy yourselves. Enjoy the sixth edition. Start enjoying it. Right? Thank you. Yeah. Over to you.
Mm, yeah. Good evening. Are you able to hear me?
Yes, Binama.
Very good
Okay.
evening, ma'am. We can hear you.
Yeah, very good. I'm going to take a session on Chapter 8, Facility Management and Safety, that we call as FMS. I know all of you will understand, or the hospital, including the patients, everybody will come to know that there is an assessment coming when you start seeing the engineering team running around, painting happening here and there, water quality is being checked, and overall the phase shift happened to the hospital, etc., etc. So it's one of the chapter which cover the facility and the safety, and the standards are designed to provide a safe and secure environment for patients, their families, staff, and visitors. The FMS chapter as such include 7 standards, 43 objective elements, and 11 core elements. Out of these 43 objective elements, 11 are core elements, 29 commitment, 2 achievement, and 1 excellent element. That itself tells that a hospital which is going first time for assessment itself need to address majority or maximum of the objective elements of a facility management system. The presentation now going to highlight not the entire objective elements, but it is going to highlight the changes from 5th to 6th edition of the standards. What we need to notice that while no new standards have been introduced, few interpretations have been modified to bring more clarity. Example, FMS 3A, which focus on a security manual, and FMS 7B. This is a new objective element which address non-fire emergencies. As traditionally, even assessors, we go and check for the fire safety, how it is handled. Sometimes we overlook when the objective element was combined together. Now, with a new objective element, FMS 7B, we are going to address the non-fire emergencies. And again, few interpretations have been modified to bring more clarity into the standard requirements. Next slide, please. Next slide, please. Yeah. Next slide. Yeah. Here, FMS 1E. This is something where there is a change from excellence to commitment. All of you are aware in 5th edition, we were covering this in the excellence standard. That means a hospital which is going for re-accreditation, we're looking for the standard tool for before construction, renovation, and expansion, how the risk assessment is being carried out. But however, when you look into FMS HIC 4B in the 5th edition, now which is updated as IPC 4B under the overarching element of a commitment. So to emphasize on the use of a validated tool for infection control risk assessment. Correspondingly, this was not matching with the commitment standard of the IPC. So we have changed now. FMS 1E shifted its focus to excellence to commitment to align with this approach. The risk assessment must be conducted prior to any construction, renovation, or expansion activities addressing risks such as noise, vibration, and infection prevention control. So this will match with the HICC 4B of the 5th edition or IPC 4B of the 6th edition. Next slide, please. Yeah. Next slide, please. Yeah. Now here, FMS 2A. Again here, there is a slight change, that is infrastructure to cover from the COP 9D. COP 9D talks about the modification of infrastructure. So here in FMS 2A, to cover that, interpretation have been modified. So here, next slide, please. The organization endures to upgrade its physical infrastructure to meet national, international guidelines. The infrastructure and equipment shall be upgraded, commensurate with the scope and complexity of the functioning. Now, when you are upgrading the hospital infrastructure, this involves adhering to national, international guidelines to ensure safety, efficiency, sustainability, and compliance with the healthcare standards. If you look into the next slide, please. Yeah, next slide, please. Previous slide, sorry. Previous slide. Yeah. If you look for the what are the national standards or international standards, you can refer into the Ministry of Health and local regulations, especially National Building Code in India. This is what we are going to look into. Then again, you can look into the accreditation standard. If you look into the NABH 6th edition standards, different areas we are talking about the infrastructure requirements. So you can look for that. Then again, there are international guidelines, that is the World Health Organization, WHO, requirements for evaluate the hospital resilience in emergency and disasters. Then international health facility guidelines, health technical memorandums of UK, facility guidelines include institute from the US, etc., etc. Mostly all these references given at the end of the chapter, but it is good before you run for an infrastructure change. Just because an NABH assessment is coming, you need to understand exactly what are the guidelines or what adherence to the facility requirements you need to implement. Next slide, please. Next slide. Next slide. Yeah. The organization environment facilitate operate to ensure the safety of patient, their families, and staff and visitors. Here again, a slight change is happened. Next slide, please.
Not audible. मैडम मतलब सितंबर 2025 आप जो फीस जमा करवाएंगे वो सितंबर 2025 से आगे तक की होगी।
Dear all, there is some technical glitch. Please be there for a minute. We are just looking into it.
Appears that meanwhile, I'll just look at what is there in the chat box. So, am I audible?
Ma'am, you're audible, ma'am.
Yeah. So it appears that the link which I have posted is not opening. So I think it should open sooner than later. I mean, there must be a reason, technical reason as to why the link is not opening. Please follow the portal and keep following. Even if you Google it, at least you're able to reach that link, right? So there's a guidebook. Maybe there is a technical reason. Please follow it through. In addition, please look up the chat box. Air Marshal Dr. Pavan Kapoor sir has given the difference, a very nice difference between what is governance and what is leadership. So governance lays down the
Hello?
structure processes.
Can you
Yeah,
hear me?
yeah. Okay.
Yeah,
Over
but
to
I
you.
am
You're
able
audible.
to see the PPT.
One second, ma'am.
Yeah. The flow will go.
Now you are
Yeah.
able to see the PPT, ma'am?
Yes.
Okay,
So
ma'am.
the FMS 2B, I'm so sorry about this technical issue. I hope I will be able to continue further. Okay, FMS 2B, though we have not mentioned here, the interpretations have modified to add extra low voltage and IT network. So when you are doing the drawings or the plan, you need to include now extra low voltage. That is all your telephone connections and IT network into the drawings. Okay, now coming to the FMS 3, the organization's environment and facilities operate to ensure the safety of patients, their families, and staff and visitors. Next slide, please. Next slide, please. Can you hear me? Oh, what is this here?
Audible, Binama.
But no slide is not moving.
Just let it just go slow. There is a lag. It's taking time.
Yeah, it's coming now. Okay, so here there is a change in the interpretations, added little extra, that is written guidelines on security of patients, visitors, staff and materials shall be incorporated in the form of a manual. And the planning process shall begin by identifying various categories of people in a hospital. Now, this is the extra added. You all aware about the safety concerns a hospital face nowadays. So to address this point, this particular point has added, what you need to remember or the points to remember is number one, identify different categories and areas. Now identify different categories. Who is this identify different categories? That is your patients, different category of patients, your staff, the visitors to the hospital, and the employees of the hospital, and the areas, especially vulnerable areas. What is this vulnerable areas? The areas where security cover may be less, dark areas, long corridors where night duty staff stays. All these areas are supposed to be the vulnerable areas. So as a hospital, now operational security plan with the details of access, appropriate security measures, etc., shall be covered under this FMS 3A. That is why this is included in the standard objective element now. Next slide, please. Yeah, next slide, please. Next slide, please. Next slide, please. Can you hear me at least? Hello?
You are audible.
So I must make myself visible also, so at least you all can look at me and how desperate I am now.
No,
There is
all
nothing
videos,
else I can
because of
do.
the lag. All videos are interesting.
Or without slide I can talk, no issues. Yeah, here comes the thing. FMS 3C is changed from achievements to commitment. As you are aware, again, the electrical safety audits is a mandatory statutory requirement in any state where the hospital cover the safety issues. But in the previous standard, that is in the 5th edition, this was coming under the achievement. Most of the hospital, though they have the report, we were not able to score it, neither we were auditing it. So to bring in par with the statutory requirement, this was changed from achievement to commitment. Now, what is the electrical safety audit? Here, what the hospital need to have is an electrical safety audit, which is a systematic evaluation of a organization, electrical system, process, and infrastructure to ensure compliance with the safety standards. So this compliance with the safety standards, it is going to be a third-party audit or the electrical engineering team. Most time in the hospital, what we implement as a electrical safety audit is an internal audit where the quality or the facility team do a electrical safety or fire safety audit and submit it as a electrical safety audit. But here what we are looking is the audit by the appropriate authorized statutory person or the authorized officials of the electricity board, etc. They will submit a audit report. Sometimes this is, in some states, this is assigned to approved third party. So depends on that the hospital need to develop. So the objective element is shifted from achievement to commitment. Next slide, please. Yeah, the organization has a program for medical gas, vacuum, and compressed air. Here, FMS 6, next slide, please. FMS 6B and 6C is combined together and made it as a FMS 6B. Here again, what are we going to look is the standardized color coding of the cylinders and pipelines, safety issues of at all levels, alarm units and valve boxes installation, etc. So whichever is in the orange color is the change we have brought into the interpretation points. Yeah, next slide, please. Next slide, please. Yeah. The FMS 7 standard, the organization has plans for fire and non-fire emergencies. Next slide, please. Yeah, here again, next slide. Next slide. So this FMS 7B, it has to you change, yeah. So FMS 7B, the organization has plans and provision for identification and management of non-fire emergencies. This is a new objective element. Most of the time, as I told you in the earlier, we were looking for the fire emergencies. Whenever we ask for a mock drill of a disaster, most of the time it comes with a fire emergencies or something like that. Here in this objective element, we are addressing to the non-fire emergencies. The organization shall take care of non-fire situations by identifying them and by deciding appropriate course of action. So first step is identifying which are the situations based on the location of your hospital and the risk involved. For this, a good risk assessment chapter or the risk assessment will help you. So please include in the objective elements requirements as terrorist attack, invasion of SAMS and infect. Next slide, please. Invasion of stray animals, civil disorders affecting the organization, antisocial behavior, mob violence, etc., etc. Most of the time, the hospital faced with the civil disorders or fights. Good examples are there across India. It's happening. So the hospitals need to develop SOP for this, and you need to submit it as an evidence when there is a mock drill happening. Yeah. Next slide. Yeah, this is continuation again. Sudden flooding of areas, for example, basement due to clogging in pipelines, or there are hospitals which face flooding of the basement when there is a severe rain or something and there is no proper drainage system. They'll end up in flooding, and the basement with electrical facilities and all come across with a standstill. So we need to identify this non-fire emergencies, how you are going to handle this. So this you can refer the national or state disaster management guidelines for this. Yeah. Yeah. I'm sorry for the voice issues. It's very much getting disturbed here. I'm not even able to see the slides properly. I'm sorry for this disturbance. If you have any questions, you may ask now. But please do remember, FMS chapter, no much changes, except that a security manual need to be included, and address to the non-fire emergencies. Other slight interpretations are to bring clarity. So hospitals now, next edition onwards, you need to address it with a security manual. Thank you. Yeah. Should I take the questions now, or are we moving to the next?
Ma'am, we can take one or two questions, or we can
Yeah.
take it in some time. Before that, we can have Dr. Priyanka Chauhan's session.
I am okay in whatever way. I hope by that time my net connectivity or that side connectivity will improve.
Yeah, surely, ma'am.
Yeah.
Okay, now I would request Dr. Priyanka Chauhan, Senior Product Manager, Digital Health Lead at NABH, to update us on NABH digital health programs. Over to you, Dr. Priyanka.
Thank you so much, Dr. Priyanka, for that introduction. And I'll quickly go through the digital health programs at NABH. I hope everyone can hear me loud and clear.
Yeah, you are audible.
Great. So I'll quickly go through the digital health programs that we have at NABH. So as everyone knows that, NABH started way back in 2005 and released its first standards in 2006. Following that, as the entire India, and there's a movement in the movement of digitalization within our nation, and we're moving towards Viksit Bharat and Vision 2047. You can see all that digitalization happening in the fintech industry, right? At this point of time, it was very important and, in fact, imperative for NABH as well, not just to take the the internal transformation journey that it is already ongoing, but also to make sure that the hospitals are as well up to that standards to get digitalized. For that purpose, NABH launched digital health standards for hospitals in September 2023. So far, we had 3 rounds of digital health assessor trainings and have about 140 assessors trained so far, right? We had a great kickstart on digital health standards for hospitals, wherein about 100 hospitals were felicitated on National Patient Safety Day on 17th of September 2024. Apart from that, we have also received about 250 more applications, and we continue to receive about 15 applications each month. Right on your right side of the slide, you see a snippet of of some of the hospitals which were felicitated by the QCI chairman, Mr. Jakshish Shah, by Mr. Rizwan Koita, QCI NABH chairman, and by Dr. Atul Kochar sir, CEO NABH. Now, given that I would like to emphasize that the digitalization, it's not out of the blue that these standards were created. It was to make sure that the hospitals, we give a helping hand to the hospitals towards this digitalization initiative. So all the standards, all the chapters which have been kept for digital health standard hospitals have been made sure that they're in complete alignment with the NABH standards for the hospitals, right? So if there was an AAC chapter in the standards for hospitals, NABH standards for hospitals, the AAC chapter still remains in NABH digital health standards for hospitals, right? Also, likewise, it follows the same pattern. Plus, we do understand that some of the hospitals, it's only a starting phase for them, a stepping towards the digitalization. So they've been kept very simple at this point of time, given that there are 3 maturity levels: silver, gold, and platinum, right? With having very minimum amount of excellence and the achievement categories to be fulfilled. It's only if a particular hospital only applies for a silver category, it is only that the core objectives have to be fulfilled and some percentage of the commitment categories have to be complied with. I can talk much more probably in the upcoming sessions or program of implementations that NABH hold, but just wanted to get the participants familiarized with these kind of standards that exist with NABH that helps them in getting accredited and certified on digital health standards for hospitals. Apart from that, while we were working on the strategy for digitalization of the hospitals, it was imperative that we also introduce standards for HIS and EMR. Right now, we have a very fragmented market on the HIS and EMR, right? When some of them we call it as HIS, some applications we call it as HIS, some of the applications we call it EMR. So how do we make sure that we are using one of the best EMR and HIS? How do we make sure that all of that HIS and EMR is eventually going to be helpful for our hospitals, right? For that purpose, in this year, 2024, NABH launched the digital health standards for HIS and EMR programs. Can we go to the next slide, please? Yeah. So these standards for HIS and EMR were launched. Now, this was to make sure that what is being offered in the market to the hospitals is also standardized, right? So at this current moment, what happens is the HIS and EMR standards, they reach out to the hospitals, with very various amount of offerings, and there's a lot of customizations that go in place that basically increase the cost of implementation as well. What we intend to do here is standardize these HIS and EMR in the market, and which helps the hospitals in adopting these HIS and EMR, applications in the hospitals as well, right? So at the moment, there are 2 levels of maturity, which is basic and advanced. We've kept it really simple for everyone to adopt these standards. We recently held workshop for HIS and EMR vendors. Having said that, it was very well received. Within the span of about 2 to 3 weeks, we've already received about 30 applications from the market, from the HIS EMR softwares, which is a good number given that these softwares, these would be less than 80 to 90 as of today in India, right? Having received just 30 out of within 3 weeks, I think it's quite an achievement in itself. So all that I'd like to stress on at this point of time is also that the standards for accreditations are in alignment for NABH, are in alignment with NABH Digital Health Certificate for hospitals, which is also in alignment with NABH Digital Health Certification for HIS and EMR. Now, this is a win-win situation for the hospitals as they get standardized product. The RFP is well in front of you, right? all that you need to ask is, give me an NABH certified HIS, and I'll have all those workflows already digitalized within the EMR applications. The hospitals, for a win-win for the EMR is that they have to undergo very less amount of configuration and customization to meet this requirement of the hospital, because they have the requirement very well given to them by NABH, saying that these are the standards that we require in the market that will help us adopt NABH standards as well. So having said that, it just penetrates, the NABH standards, the standardized workflow will also seep down to tier 2 and tier 3 cities with this kind of a strategy, and making sure that digitalization helps the patients which are last in line as well. I'd be happy to take up any questions related to these two programs. Up to 40 beds.
Thank you, Dr. Priyanka.
I see question in the chat box. It's disappeared now, Priyanka.
Yeah, can the name of the vendors with the NABH training be given?
Sure. As soon as we get them certified, we will be publishing all the vendors, those who will get certified with NABH.
Also,
Mention the fee structure. As NABH, as the rest of the programs that we have, if you go to NABH fee structure, you'll find that at the end, you'll find HIS and EMR programs fee structure there as well. Yeah.
They have also asked that have you planned any tentative workshop dates?
We've just closed 2 workshops, one with the software assessors and impanel companies, and one with EMR HIS vendors, but we hope to do another one in next 1 or 2 months. We'll keep you posted on NABH website for that one.
There are certain questions regarding, will hospitals have to take NABH for NABH certified HIMS or EMR?
The hospitals, so there are 2 different programs. The hospitals will have to take NABH digital health standards for hospitals. The HIS and EMR company, the software companies per se, will take NABH digital health standards for HIS and EMR system. I hope I'm clear on that.
Yeah, surely. There have been questioning qualification criteria for assessors in digital health standards. I would say that we have been publishing the criteria for assessors for digital health standards on our website. Whenever there is next notification, you can please refer that. There is a question regarding, should OP and IP be fully digitalized for this NABH certification?
I'm sorry, I didn't get the question. Can you say that again, please?
Should OP and IP services be fully digitalized for this NABH certification?
So as I mentioned earlier, that depends on the maturity level that a particular hospital opts for. And within that as well, whether it's OP or IP, depending on the scope of the hospital and the maturity level that you choose, there are certain core criteria that definitely have to be digitalized. There are certain commitment criteria that has to be complied only up till 80%, and the commitment and the excellence level have to be complied to certain percentages only. So that would, I would say, depends on the scope of the hospital and depends on the maturity level that the particular hospital opts for.
Okay. Then there is a question regarding digital health certificate is only for accredited hospital or any HCU can apply?
So as of now, this is only for accredited hospitals. Nevertheless, it wouldn't be too early to say that NABH is planning to come up with standards for other hospitals which are not accredited at the moment. So yeah, you'll see those details come up on NABH website very soon.
Thank you very much, Dr. Priyanka. We would now like to take the Q&A sessions for FMS chapter. Thank you for joining us today and enlightening us on digital health initiatives of NABH.
Thank you so much.
Yeah, I'm back
Vinamma
here.
ma'am.
Yes, I'm back here.
Thank you very much, ma'am.
Yeah.
Okay, there have been question, if we have an access control in the terrace, do we have to deploy the security staff in the terrace?
And not necessarily. If you have an access control, that stands as a security control only. We need to have, not necessary. But when you are making a security manual, this has to be explained that these are the areas under access control, say whatever, under lock and key or a, biometric, whatever. If that is there, I don't think we need to keep a security personnel there.
Okay, ma'am. The next question is regarding how frequently do we do electrical safety audit?
It is mandated annually. It has to be done every year. Some states it insist on by the third party, which is an authorized, approved third party, need to be done it. There was one question on whether internal person can do. They can do it, but it is one of the statutory requirement for building safety. So it's better not to take a chance on it. Uh, it's a bit expensive process, but it is something which we can't prevent. You may have to do it with the external agency, which is approved by the statutory bodies. That is it. But for a safety, there are areas where you may have to do it frequently. That can be done internally. But the overall electrical safety is recommended annually. So the assessor comes, you may have to show the annual report on electrical safety.
Okay, thank you. Then there is another question. Is there any special color coding for hazard material storage?
And there are different systems for disaster material storage. There is no color coding. As such, no color coding. There are different systems like diamond and all that. Whichever system you are following for your own hospital can be used. No specific color coding for that. As of now, we are not looking for a specific color code for different hazardous materials. There are signages are available, hazardous signages are available, but no color coding. And those caution colors, as per ISO standards, the caution colors are the amber yellow. So that can be used as a caution, but there is no specific color code.
They have also asked, can you elaborate regarding the contents about security manual?
Yeah, this is something, a new concept we have included. Before also this was there. You must remember operational planning of security areas were there, but it was not mandated as a written guidelines. Now in this standard, this has become an asterisk met. If it is an asterisk, that means a written guidelines should be there. And what we need to include in is, number one, you need to develop a format for this. So the content can be what are the security concerns you are identified. Okay, based on that, what system control you are going to put. For that, you need to identify first the operationally risk areas of your hospital. Then based on that, again you will have to develop which are the categories of people. So a framework you can do for the security manual. You can do a framework starting with the identified risk areas, then identified categories of staff. This is what, and what are the system control in place. For example, if it is MRD, you may have a authorized person or a biometric to enter the MRD. In the terrace, maybe it is only the engineering team, but say, for example, critical care areas, only the concerned staff and doctors will enter. Others may require a permission or a reference doctor may enter. Other than that, nobody is including the other category of staff don't enter. So the most important part here is to identify the category of people and what level of access you are going to give. Say, for example, the top management room, everybody may not enter inside without a approval or an thing. Okay, so that is the way you need to look into. Hello. Am I audible? I
Yes,
get a
ma'am, you are audible.
yeah, yeah. Is
Yeah,
that
there
covered?
is little lag, but
Anything you have? So most important, when you say this is vulnerable area, you must remember
Mhm.
the previous Calcutta Medical College incident. This was one of the vulnerable area at a vulnerable time and a vulnerable staff. I hope you understand. So such areas, what system you are going to put? So an elaborate security manual you can make on it, and it should be accessible to everybody. The staff who is handling all this security personals need to have an access to this manual, and the staff must be trained also, though this is not mentioned in the objective element. Unless you have a manual but your staff is not aware which are the risk areas or which are the restricted area, the intent may not be met. So please work on it. Yeah.
Okay, ma'am. Thank you very much. Thanks a lot. Some of the questions have been answered by Dr. Monica Gupta in the chat section. So
Okay,
you
okay.
people can please go
Yeah.
through that.
Yes.
And now we will break for 10 minutes for tea break. We will again start the session at 4:50. Afternoon all. Welcome back. We will now be starting with the session on HRM by Dr. Rajiv Kumar. Dr. Rajiv Kumar, sir, please.
Yeah, good evening. Slide is not visible.
It will be
Priyanka,
displayed. Yeah. 1
yeah,
second, sir. It will be displayed,
yeah.
sir.
Hi, good evening, everyone. So now I'm starting another very important chapter, HRM, Human Resource Management, because we all know that without human resource, no one can do anything in any organization, and especially in the healthcare organization, where we need a appropriate number of and skill mix of people to deliver safe healthcare in the hospitals. So there are minor changes, few changes in the 6th edition. If you see from the 5th edition, so on now we don't have any excellence objective element in the 6th edition of the chapter number 9. Standards remain the same, 13. Now 76 objective elements in the chapter HRM chapter. So we will discuss what are the changes done by us in the 6th edition. Next slide, please. So first is the organization is a documented system of human resource planning. So here we have added regarding the number of what do you mean by staff and all. Next slide, please. Yeah. So we have changed from excellence level. This was human resource planning was at the excellence level. Now it's at the level of commitment. Okay. So it will be assessed at every assessment, from the final assessment to renewal assessment. Next slide, please. Here we have added we have added interpretation to emphasize application of the objective element to all the staff. So the requirements of this objective element, if applicable to all types of staff who require JD, job descriptions, for example, full-time, part-time, impaneled consultants, employed, honorary consultants, voluntary or temporary basis, many people are coming as a student for 15 days, 30 days, observership. So all these staffs whoever are coming to work in the hospitals should have a JD. Many hospitals during assessments, no, we don't have a JD of the consultants who come once in a month or once in 1 year. So that's why we have clarified in this objective element of HRM 1D. So you should be very clear regarding the what do you mean by staff. Next slide, please. Next is reporting relationships are defined for each category of staff. Reporting is organogram, organizational structures. Okay, every that is already discussed in the we have in the RM chapter. So organizations should have document as the organizational chart or hierarchy, line of control, along with the functions at various levels. An organogram should be transparent and it should be disseminated to all the stakeholders in the hospital. And the reporting relationship at the department level, service level should be also defined. They don't know to whom they are reporting for what. So reporting relationships should be crystal clear with the line of control, along with the functions at various levels. And it should be transparent and it should be disseminated to all the stakeholders throughout the organization. Next slide, please. Next is organization implements a defined process for the staff recruitment. Next slide, please. I believe there is no change, only content is changed. Yeah, in HRM 2C, the organization defines and implements a code of conduct for its staff. The code of conduct shall outline the do's and don'ts for the staff behavior at the workplace in the hospital, and it should be aligned with the organization values and organizational ethical framework. We already discussed in the RM chapter. And the code of conduct could be part of the service rules of the organization as per the organization policy. Okay, that is the only line statement we have incorporated here in HRM 2C. Next slide, please. Next is HRM 3. In HRM 3 only we have added revision content so that it should be better clarified and for the implementation. And that is staff are provided with induction training. All the staff, including volunteers, students, trainees, are also oriented to the hospital and their specific assignment or responsibilities, what they are doing in the organization as per the needs of the volunteers, students, and trainees. And previously, it was in the 5th edition, the induction training should be done within 15 days. Now we have expanded, given liberty to conduct the induction training within the month of the staff joining. So you have to conduct induction, you have to complete the process of induction training to all the new joinees within a month of the staff joining. Next slide, please. Please go back. Please go back. Priyanka, please go back. Some slide. Yeah. 3A, then 3D. 3D. Can you go to 3D? HRM 3D. 3D, go back, go back. Going backward. Yeah. Please go back one slide more. Yeah. 3D. Next slide, please. Yeah. So next slide. Yeah. Yes. Thank you. So here you have to do impart training on the CPR during induction to all the staff, especially basic life support as per the newer guidelines. AHA has published CPR guidelines November 2024. I believe many of you have already gone through it. So please go through it. Only minor few changes done in the AHA CPR guidelines, November 2024. Next slide, please. So all the doctors, nurses, that is already in the 5th edition. Okay. Only we have added the line in case the staff has a valid training cert. That was also in the 5th edition. Next slide, please. Yeah. Here we have this is a new, only one new objective element we have added in the HRM chapter. Staff is trained on information systems, information security, information use and management, because now there is a digital transformation in the hospitals throughout the world. Global digital transformation is happening, and we are moving along with what is happening in the world. So this is very important in the future, for the future in the hospital. So all the staff, especially consultants, doctors, should be trained on the use of information systems according to their job responsibilities, job descriptions, and data and information is what are the data and information needs for the staff, for the management. Madam Vinamma will discuss all these things in IMS 1. Okay. If the organization uses EHR, electronic health records, the staff who need to access, review, and or document in the EMR shall be trained to ensure use of the same. Because many hospitals we have seen, senior doctors are giving password and all. You please do it to the resident doctors, senior residents, registrars. So doctors, senior doctors, all the staff should be trained how to access, how to review, and how to document in the EMR. So all this training should be also part of the induction training. I'm talking about induction training in HRM3. This is the new addition for the content of the induction training for each and every hospital. Okay, next slide, please. Next is ongoing program for the professional training development of the staff. Next slide, please. Next slide, please. Yeah. So this is already was there, training manual. Next slide, please. Yeah. So here we have added how can you do this? So learning management systems and e-learning models could be used for the ongoing program for the training and development of the staff. This is another challenge area for most of the hospitals during assessments, and we have a challenging challenges while doing audits, assessments in the HR department, especially for the training. And what do you mean by learning management system? So learning management system is a software application. Again, I'm talking about the systems, software applications, or web-based technology designed to facilitate the administration, documentation, tracking, reporting, automation, and delivery of the training courses, training programs, or learning and development programs in the hospital. Okay, so how to create learning management system in the hospital? You can take help from the IT guys, those who are good in this LMS, learning management system, and e-learning modules, and how to create courses, then upload course materials in videos, PDF. Many hospitals are doing like this. You can create quizzes, quiz questions, assignments, assessments. Okay, and how to manage learners, and you have to assign roles and permissions also. And then by you can track by monitoring learners activity in course completion and automation. You can do that do like that by putting notifications, reminders. You have not attended the training program so far. Many hospitals I have seen while doing the assessment. Okay, so this is called a learning management system. So there are many platforms available in the market, so please go through it, whatever the suits you. So, or you can customize yourself at the organization level also with the help of IT guys. What are the e-learning models? So that is actually interactive digital resources designed to teach or teach a staff on specific topics like hand washing and all. What are the topics? What are the challenges you are facing in the hospital? Okay, like doctors are going outside the OT in a scrub dress. So I'm just sharing few topics for the e-learning modules. Okay, and it should be in these days, in the present times, I suggest it should be a mobile friendly, so that any doctor, any staff of the hospital can access on the smartphones and tablets. Okay, so this can help you in the ongoing program for the professional training and development of the staff in your hospital. Next slide, please. Next slide, please. Yeah. So this is another challenge for the quality team, HR team, nursing team, and other staff in the hospital. Every time, who is getting NCs? HR. This is not my job. Why I'm getting NC? So now NABH is saying we have added training records could be in digital format, but at a minimum, it shall include the title of the training, trainers, name, date and duration of the training, list of the trainees with the name and signatures. Okay, and it's wherever possible, please keep contents of the training materials. What are the training imparted to the participants? Next slide, please. HRM4E. This was the actually at the excellence level, and now it's at the achievement level. Evaluation of training effectiveness is done by the organization. This is another challenge for the HR and other training providers in the hospital. Okay, so there is no change in the interpretation, only we have changed at the from the excellence level to achievement level. This will be assessed at the surveillance assessment onwards in any organization. Okay, next slide please. Yeah, staff are appropriately trained based on their specific JD job description. Next slide please. Next, yeah, only change here we have added content to interpretation for better clarity. On the CPR, the staff involved in direct patient care are provided training on the CPR periodically. Okay, now we have defined the periodicity that should at least once in 2 years, or earlier if there is change in protocols. Now protocol is changed in few areas as per the AHA guidelines 2024. And the hospital should identify the level of training, basic or advanced life support, appropriate to their roles in the hospital for all the staff who are providing patient care in the hospital. The desired level of the training for each individual is repeated based on the requirements and or time frames. Whenever you are doing evaluation of the training effectiveness based on the reports, okay, so you can do more frequently training on the CPR to the identified staff. Next slide, please. All the doctors, nurses working in emergency, intensive care, high dependency units should go for training, advanced cardiac life supports, advanced trauma life supports. We have added, it was not previously in the 5th edition. Now we have added those who are working in the trauma center, in the emergency department, in the orthopedics. So you have to impart training on the ATLS, pediatric advanced life support. If you are admitting pediatric patients, if you have a PICO, and NRP, that is a neural resuscitation program. If you are admitting neonates, or if you have a delivery center, so the staff, doctors, nurses should be trained on these resuscitation programs. Next slide, please. Yeah, this is on the staff are provided training on the infection prevention and control. So it was there, only we have added, it was missing. We have witnessed and experienced while doing the assessments. So that's why we have added in-service training on the infection prevention control should also include antimicrobial policy and antimicrobial stewardship program for the medical professionals, infection prevention and control nurses, clinical pharmacists, and other support staffs who are involved, like in making antimicrobial policy and who are taking part in the antimicrobial stewardship program in your hospital. Next slide, please. Next is SHAM 6. Staff are trained in safety and quality related aspects. Next slide, please. Only we have added few things in the contents to make for better clarification. Staff are trained on the identified aspects of safety, including patient safety in the organization. So whatever you have identified, so that should be also part of the safety education program in the hospital. Okay, next slide, please. So PSQ1 says about the patient safety program. So you have to train your staff based on the hospital patient safety program. So it should be always kept in mind while imparting training to the staff. Next is HRM 6E. Staff are trained in the organization's disaster management plan. So whatever plan you have on the DMP, so you have plan means disaster management plan for both external as well as internal disaster, whatever you have identified. So we have discussed in the FMS chapter before this chapter. In the FMS chapter, whatever you have identified, what could be internal disaster in your hospital. So you have to train people with the external disaster management plan in the hospital. Next slide, please. Yeah, staff are trained in handling fire, non-fire emergencies. So staff in the organization we have added people are conducting training on the fire, mostly fire, not on the non-fire, because they have not identified after doing risk assessment in the hospital. That is very important. While doing risk assessment, you have to identify what are the risks involved in the hospital, what are the other than fire it can happen in the organization. Those you have to identify non-fire emergencies in the hospital. Okay, so you have to train your people on the identified non-fire emergencies, and also you have to train on their specific roles during such emergencies. What they will do during such emergencies. Everyone is being trained like one. I don't know. Everyone is confused. What will be my role as a head of the organization? What will be my role as a head of nursing in the hospital? So their roles are not defined. They are not aware of. So all these aspects should be taken care of while imparting training on the fire and non-fire emergencies management in the hospital. Next slide, please. Appraisal system. This is same. Next slide, please. Only we have in the HRM 7, we have changed from the achievement level to commitment level. The appraisal system is used as a tool for further development. The interpretation remains the same. Next slide, please. HR 9A. So here we have added content in the interpretation, modified, and we have also added some written guidance, if I am correct. The organization has the health problems of the staff. Here we have written health problems of the staff, including occupational health hazards, are taken care of in accordance with the organization's policy. The organization has a written guidance. What is written guidance? Without written document, you can't guide your staff. So there should be written guidance. So for the staff of the hospital, they will read it and that document will guide on staff health and safety program that addresses staff physical and mental health and safe working conditions. So there should be a written guidance on the staff health and safety program. That is very, very important. So it was not previously there. So we have added here in the HRM 9A, the organization shall make appropriate arrangements for safety of a healthcare workers at the workplace during all shifts, all the shifts. Okay, so this is very, very important. Next slide, please. Yes, the organization develops and implements a staff vaccination and immunization program. Okay, the organization shall support the staff. Second victim involved in unanticipated adverse events, medical error, or patient's related injury. I believe many of you must be aware of second victim. Okay, what do you mean by second victim? Actually, second victims are the victim healthcare provider who is involved in unanticipated adverse patient event in a medication error, patient related injury, and become victimized in the sense that the staff is traumatized by that event. And it happens. I'm just sharing a long time back. There was one study in 16 or 17, I don't remember the year, but it's more than 7 years back. There was a survey conducted on surgeons, operating surgeons. And that survey revealed that 80% of surgeons they told in the survey at least one intraoperative adverse event in their practice in the last 1 year happened. And the affected operating surgeons also reported those events had a substantial emotional impact on their well-being. We will discuss staff well-being. We already discussed. Okay. And including strong feelings of the sadness, anxiety, and shame. And some to the extent they also needed formal psychological counseling. You can also Google it. Please read and try to understand. And in every organization, every doctor, at least, not doctor only, 50% of the healthcare worker could experience the impact as a second victim at least once in their career. I'm also a victim, but I was not aware at that point of time when I was practicing pediatrics, working in the pediatrics. I will not say what actually happened. But today I feel I was the second victim. At that point of time, nurse was second victim. So please go through it and please try to understand, because this is a very important staff and health written guidance, how to manage those second victims. That is very important, because mental health impairment among health clinical staff due to workplace stress, we have already seen during COVID pandemic, high levels of depression, anxiety, sleep disorders, burnout, other injuries. So all these things happened during COVID. So that's why now NABH is saying support, and you have to create programs to support involved in the Sentinel event, serious adverse event, and to proactively develop skills to promote staff resiliency, staff health, and staff well-being. So this is the requirement here in HRM 9 on the how to support. What will the mechanism for the second victim staff in your hospital? Next slide, please. Yeah. Next is HRM 90. The organization has a measures in place for prevention and handling workplace violence. So I believe there is no change. And next slide, please. Yeah. Yeah. So only we have added we are talking Madam Binamma was talking about security manual and in the FMS 3A, and the above should be part of the written guidance on the security also, how to manage, how to handle workplace violence, and you have to incorporate workplace violence also in the FMS 3A manual, security manual. Okay, next slide, please. Next slide, please. Priyanka, next slide. Rohit is there. Oh, okay. HM 10, there is a documented personal information for each staff member. That is personal file. Okay. Only few objective elements modified for the better clarity. Next slide, please. Yeah. Personal files, voluminous, no place, big institutions, 1,000-bedded hospital, more than 500,000 staffs, how to keep, how to store personal files, how to handle. These are the challenges our accredited hospitals are facing throughout the country. So the basic intent is each file must be current, updated, and could be in electronic format. You can scan and keep in the electronic format. Okay. But you should maintain confidentiality and access to the personal files, electronic format files also. Next slide, please. Next slide, please. Yeah. So again, the records of the in-service training we already discussed in the induction training, ongoing training. So all the records of the in-service training and education program should be contained in the personal file, and you have to identify and summary of the trainings of the staff on which you will be or those staffs which topic will be given on annual basis, and the staff of hospital wide training and department specific trainings. Okay, so you have to keep all the records of the in-service training. And whenever there is a doctor also going for the training or CMEs, all these records should be part of his or her personal file also. And electronic training records are acceptable during the NABH assessment by the NABH team of assessors in your organization. Next slide, please. HRM 11. So nothing is changed. Only we have changed from the MCI to NMC, that is National Medical Commissions. Okay. Next slide, please. Only few words we have, if I'm correct. Yeah. Next slide, please. Yeah. Here, 11B. So all the credentials required by the organization are documented and maintained for each medical staff member in his or her personal file. Okay. Next. Next slide, please. That's it. Thank you. If you have question from this
I will
chapter.
take up the questions.
Yeah.
Okay. Health policy for all staff is mandatory.
Yeah. Staff and health policy is mandatory. In what context you are asking? Priyanka, can you clarify more, elaborate
Yeah,
on
they have
this?
just mentioned that for under 25 bedded hospital, I believe then there will be standards will be different
Yeah,
altogether.
different. Correct. That is the HSCO, a small healthcare organization.
Yes.
We are talking about a 50-bedded hospital.
Yes, 50
Full
bedded.
accreditation. Yeah.
Yes.
Correct.
They have asked ACLS and BLS training should be provided by AHA trained instructor only. Is it compulsory or anyone else can provide?
We are very clear for the last 4 years, especially 4 years since 2020, if I'm correct. We are wherever we are going for the training, and during POIs also, online POIs, on-site POIs also, NABH does not recommend or mandate for the HA certified trainers. We need the outcome of the training. That's why we are asking for now that we have changed from the excellence to achievement, evaluation of training effectiveness. Why you are imparting training for the NABH only, or to save patients in your hospital? That's my clear question. We are saying you have to make the system robust. That's why you are more periodically you are imparting training to the to save patients in case of cardiorespiratory arrest in the premise. So the training should be done by the trainer who knows each and every step, everything about the HA guidelines, and you have to also check the trainers' competency also. So these days, many organizations, they also evaluate trainers' competency. People are saying training nurses are not doing, doctors, RMOs are not working very well, despite of we are spending money, time and all, but they are not performing well. So no one checks the competency of the trainer. If you have to identify your trainers, if you don't have anesthesia department, if you don't have a intensivist, okay, if you don't have a ER physician, if someone is competent, there is no problem. You can, that they can deliver the same thing, and you have to increase the duration, not in half an hour just for the name's sake. Please don't do like that. That's my suggestion. It will help. That is not a mandate from the NABH. We are very clear. Clear? Yes.
Okay,
Priyanka?
sir. They have further asked, does the code of conduct should be given to staff along with joining report or GD or appointment letter?
Yeah, code of conduct, NABH says whenever you are imparting training, just 10 bullet points, 20 bullet points on one paper, A4 size paper in English, and that staff can't read, can't understand. So someone has to interpret what are the why we are giving it, what are the service standards for the organization, for the departments. Okay, so then after explanation, and you have to check whether the staff has understood or not, and then you have to keep signature, so that is the proof you have told, and the staff has understood. Okay.
Okay, sir. They have asked that JD for consultant should be separate from privileges or the same.
Yes. Any place is very clear in the HRM1 since first edition. Okay, you have to give JD. JS should be with the HR department, on which you have you can select a staff, especially doctors. So what is the minimum criteria qualification? Okay, for that specialty. Then you have to what he or she can do, and then you have to give JD. Job description should be very clear, and based on the what consultants are doing, or on the competency level, the consultant will ask for the privileging, and then based on the competency, the committee, CNP committee, or whatever you have in the hospital can give a privileging. You can do only this, you can't do that. Okay, so that is two different things, not same thing.
Okay, sir. Then they have asked, can they show digital training records in personal file?
Yeah, digital, yes, photocopy, or you can keep on the computers, or some tracker should be there, just click, it will open by the doctor's name or the staff name. You can keep. There are many ways to keep digital records, scan records, you can say, or digital records. Not Excel sheet is not acceptable. I would like to clarify here. Excel sheet is not acceptable. Clear? That should be scanned, signed by the trainees and by the trainers. Okay? Yeah.
Okay, sir. Then they have asked if the HR file of the outsourced staff is necessary or is to be in the same format as for the full staff, full-time
Staff,
staff.
which is what?
Outsourced staff, sir.
For what? For which outsourced JD?
Personal files
Personal
of
files,
outsourced.
yes. We are very clear since third edition or second edition. All the personal file of the staff should be in the hospital, whether in the HR, or if your outsourced agency is working there, there's an office, they should keep. But during the assessment, it should not happen like this, or that person is sitting in Ahmedabad, they will come to Surat like that in next day. No. So files should be there. What are the requirements? What are the trainings you have given? All these things should be all the staff, for all the outsourced staff as well. I know this is a challenge for many organizations, but this is required.
Okay, sir. Another question
Now there
is
is
can we...
Dr. Mr. Anuruddh Chatterjee is saying personal files in both ways. You can ask, you can tell the outsourced staff, we need all this documentation, and after training, you should keep in the hospital premise, and you have to also go through it, what they have done as per the requirement. So all these things should also come in the MOU also. Many I have seen in during assessment, many hospitals are also documenting in the MOU of the with the outsourced agencies also. These things you have to keep, and you have to impart training and all soft skills, hard skills as well.
Okay, sir. Further, they have also asked, can we show DNB students as RMO, list of RMO for which hospitals are asked for?
Yes, DNB is a teaching program. They are students, but they are working as a first year resident, second year resident, third year resident. I'm talking about the broad specialty. Super specialty after MD or MS or DNB, in broad specialty, they are doing a super specialty. Okay, they are working as a senior resident one, first year, senior resident second year, senior resident third year. That is the mandate as per the government of India, or NMC, or NB. Okay, so they are all doctors. They are not. I'm not talking about the resident doctors. They are student, first year is to PG student, like that. Okay.
Okay, sir. They have
Yeah.
questions regarding nurse-patient ratio and all these. For that, you can refer INC guidelines, Indian
Yeah.
Nursing Council
Correct.
guidelines.
No, I always say acuity based staffing. I have learned from my best one all the our nursing assessors. We have been taught by our nursing assessors on this acuity based staffing of nurses, not play with musical chairs, 1:1, 1:4. I'm not talking about ICUs, other than ICUs, wards, patient care areas, daycare centers. So equity based is another Pandora box. I'm not going to open here. Okay. So for that, you have to attend POI. Okay. Or you can ask, Madam is here, if I'm correct. Madam Vinama is here. She can also highlight for 2-3 minutes after the IMS chapter. You can ask. So she will put a light on this equity-based staffing. Yeah. Yes, Priyanka.
They have asked, is state registration mandatory for nursing staff and doctors who provide clinical care?
Yeah, many states have like this, because without registration, you can't work in many states like Delhi, Gujarat, many states we have seen. So as per the health is a state subject, whatever state says now, so our assessors follow. That is the law. Yeah, that is required, mandatory requirement as per the law of the land. Okay. Yeah.
Okay, sir. They also have question that who can be the patient safety officer? What will the qualifications
Who
required?
has asked? Can I know the name of the participant?
Okay, he's Ravinder Yadav is
Okay,
mentioned.
nice, good question. What he is asking, Sivinder Singh. Okay, he's asking more knowledge about second victim. He has to call me after this class. Okay, yeah. So who should be patient safety officer? This is my fundamentals are very clear. Patient safety officers should be either doctor or nurse, okay, who should be knowledgeable in general patient safety, as well as all the components of the patient safety in the hospital. I am head of the institution. I can make anyone patient safety officer. Okay, and for the last 8 years, more than 7-8 years, I am patient safety officer also, as a head of the organization also. People say, "आप ही बन जाओ sir, ठीक रहेगा sir." Okay, so I don't want this, but My fundamental is please read, please explore, please go through it, how general safety is required and how, in what context patient safety is needed in the hospitals. All the components. I'm talking about the ledger. These days, many doctors are using ledgers in the operating room, outside the operating room, in the minor operating rooms. What are the hazards? I'm just taking one example. Okay? And that is very important. You have to identify during risk assessment all these things. And then patient safety officer is the guidance force, captain of the team, or you can say manager of the team, who can guide. And we have also written all these things. We have written in the PSQ1. Who should be patient safety officer? Now we have removed clinical safety officer in the 6th edition. So we have written. Sir has just given the answer. Pawan sir, just put in the chat box the answer. Yeah, patient safety officer could be a doctor or nurse, and not by the position. That person should be knowledgeable and also acceptable by the organization, by all the staff. That is also important. And fire safety officer, the security, that is different thing. Fire safety officer. Yes. Any questions, Priyanka? Next question. We have time, I think so.
Yeah, sir.
Yeah.
There are a lot of questions. I think we will take them up.
Okay. Any question?
Majorly, sir, I have covered most.
Okay,
Whichever are
fine.
left,
Thank
we
you.
will definitely cover them
Okay.
later. Okay,
Okay,
now I
fine.
will request. Thank you very much, sir. Thank you so
Thank
much
you
for
very much
taking up.
for coordinating this question answer session. Thank you, Priyanka.
Thank you, sir.
Wish you all
Now
the
I will.
best. Yeah. Wish
Thank
you
you,
all the
sir.
best,
Thank
all
you.
the participants.
Thank you, sir. Thank you.
Thank you.
Now I will request Binyama ma'am to please take up the last chapter, IMS, Information Management and Systems.
Hello, can you hear me?
Yes, ma'am, you're audible, ma'am.
So very good evening. Now this is the last and smallest chapter I can say with the changes. So chapter 10, Information Management System. This includes management information system and hospital information system, as well as modalities of communication to staff, patients, visitors, and community in general. The IMS chapter has total 7 standards, which includes 45 objective elements, out of which 9 are core elements, 33 commitment, and 2 achievements, and 1 excellence. Now, if you look into the changes from 5th edition to 6th edition of IMH chapter, no standards are added, no new standards have been added, and one new objective element on digital health technology to improve operational efficiencies is added. I think the previous session also we were talking about the digital health system. So more and more technology is capturing even in the hospital operational aspect. So we have, considering this particular point, we have added a new objective element on digital health technology with a view of improving the operational efficiencies. And interpretation of few objective elements have been modified to bring more clarity for implementation. So other than that, no major changes in the information management system. Next slide, please. Next slide, please. Next slide, please. Yeah. IMS 1A, the IMS standard itself talks about information needs of the patient, visitor, staff, management, and external agencies are met. Here, again, the IMS 1A is going to identify the information needs of the patient, visitors, staff, and external and community. One particular point, next slide onwards. Next slide, please. Next slide. Yeah. Here, it insists on what are the important information needs from management side would require. This particular point is added now as a slight change in the interpretations. So this is insisting upon what could be the importance for the management. For example, daily census report, utilization rate, etc. are important as a managerial information needs. So rest of the interpretations remain same as the 5th edition. Next slide, please. Next slide, please. Yeah, here again, IMS 1C, a modification in the interpretation by mentioning the NABH digital standards for hospital. This is a change we have brought into this particular objective element. All of you are aware, accredited and other hospital which is going for NABH digital health standards are aware that we give a lot of importance now to the digital health standards. So to address this issue, a slight modification is brought into the interpretation by adding the NABH digital health standards for hospital. Next slide, please. Next slide, please. Yeah, IMS 1E. This interpretation is modified to add downtime to be monitored of the information health system or HIS system of the hospital. Before also we were covering this contingency plan to ensure continuity of information capture, integration and dissemination, but a particular word is added now to downtime of systems shall be monitored. This is to bring into a more operational efficiency. By adding this particular point, we are ensuring that providing an uninterrupted service in case of electronic HIS system. As hospital, we do experience downtime of the HIS system or billing system get standstill, etc., etc. You might have felt, but a systematic monitoring of this was missing when we visit the hospital. So at operational efficiency, this particular point has been added. Next slide, please.
Oh, ma'am, sorry to hold you, but I was just getting a lot of messages like slides are not moving. Is it not moving for anyone?
It is moving
Is it
for
audible
me
and
this
slides?
time. This time it is moving for me. I don't know. Today something wrong with my technology.
Okay, it is okay, ma'am.
Are
It is moving
moving.
for some people.
Yeah,
It's
Priyanka, the
moving for
slides are
me.
moving, not moving for
Thank you very
us.
Shall
Yeah.
I continue
It's not
then,
moving
or
for you
you
also,
want
sir.
to? Shall I
Let's ask
continue?
others. I think you continue because slides are moving. As far as I can see, the
For
slides are
me
moving.
also slides are moving and my voice also is moving. Last time I had a problem with the voice. Yeah. Now I'll continue with IMS 1 again. The IMS 1F. This is changed from excellence to commitment to ensure that the organization have information resources are accurate and meet stakeholders requirements. No change in the interpretation. We have given more importance now by making this as a commitment standard. Next slide, please. Yeah. Yeah. Now here in IMS 1G, we have added material vigilance into the interpretations. If you remember, this was in the FMS and covering to the material vigilance. So to bring all together and easy implementation, when we prepared the standards, we were looking in the easy implementation to ease the implementation stress on the hospital. We have come to add the material vigilance into the same objective element. No other changes in this particular objective element. Next slide, please. Next slide. Yeah, this is a new standard. I don't think I need to give a lot of explanation on this, because from the previous sessions by Madam also, we were talking about an NABH digital health system. So most hospitals are now digitally expert in their own information needs. So to address to this issues and to ensure that the software systems are well in place, we have added this particular no objective elements. So what is the interpretation? The organization shall make use effort to use digital health technology to improve operational efficiency and patient safety through the use of software for different functions as such registration, billing, pharmacy, laboratory, imaging, inpatient and outpatient case records, etc. Use of artificial intelligence and data analysis to be considered to improve operational efficiency. The intent of the standard, always we insist on the intent of the standard is to improve the hospital's operational efficiency and by that ensuring the patient safety also. So all these particular points like registration, billing, pharmacy, etc. are already in most of the hospital. It is digitalized. If a hospital not digitalized all these things, we are looking for implementation of this. And please note down, this is an excellence objective element. That means the hospital gets time to implement this particular objective element. Our intent is that slowly all hospitals are going for a digital health technology to ensure the patient safety and operational aspects. Next slide, please. Next slide, please. Yeah, again, when using electronic health system, it could consider the use of features such as computerized physician order entry, clinical decision support, electronic sign-out and handoff tools, barcode medication administration. All of you are aware about it or maybe are not aware about it. So how, when we are implementing a digital health system, the challenges are many. So to give you an idea about it, we have specifically mentioned what are the areas or what are the salient features you need to address. One is computerized physician order entry. This is going to help in patient safety and reducing the work of the physicians in writing the medication order sheets. Clinical decision, AI-based clinical decision systems are plenty available. This also going to help the clinicians and others in taking a decision for it. And then handover system, as you are aware, in every hospital we find it difficult to implement a handover system, but it is mandatory for very purpose of improving the patient safety. So electronic sign out or handoff tools also can be used to improve the patient safety and operational efficiency. Barcode medication administration, another area where the hospitals can work on bringing the medication safety, is about the barcoding system. But please do remember, you have time. If you are first time going for assessment, this particular objective element is excellence. By that time you are into a re-accreditation cycle. We hope and intend that the hospitals are in par with the digitalization of their own information system. Next slide, please. Then again, continuation of it, patient data management system, automated medication dispensing, patient portals, telemedicine, virtual visits. This is something which again helping the hospital to address more and more patients' need, especially in a palliative care and all. This is helping very much. So we are looking into that. Then telemonitoring technology, electronic incident reporting. By our experience, by and large, most of the hospitals have implemented or in a process of incident reporting online. So kindly look into this when you are implementing the incident reporting. And even in PSQ, this is going to help the hospitals to have a more stabilized system of incident reporting, and electronic medical record. Don't get panic when we say electronic medical record and start implementing it. This is in the excellent mode, but please start your journey on implementing electronic medical record system in your own hospital as an excellence measures. Yeah, next slide, please. The patient IMS 3 standard, the patient cared for by the organization have a complete and accurate medical record. Next slide, please. Yeah. Here again, change from commitment to core. This is something about the unique identifier assigned to the medical records. Every medical records, when we say medical record, it's not the first page of the medical record. The entire medical sheets, different sheets, need to have a unique identifier number is available. And at the time of registration, the patients get a unique identifier as assigned, and this is reflected in all the case files. So this is to give more importance to patient identification. One part of patient safety goals, we have put this from commitment to core element. That means it is a mandatory before any hospital go on to NABH implementation to have a system of unique identifier for the patient medical records as such for the patient. Next slide, please. Yeah, here again, IMS 3B, the content of the medical records are identified and documented. This is slight change in the interpretation. So when we audit, sometimes we see that the referrals, transfer details, lab results, imaging results, and nursing assessment, nursing care plan all not become part of the medical record. When you go to the MRD, sometimes that is kept separate, and a basic outline of the medical records are kept for whatever court purpose or for audit purpose. So by bringing this particular change in the interpretation, that means the hospital need to ensure that the medical record has referrals details, transfer details, results. Even if it is in the digital form, we are okay with that, but need to have it as a part of the medical record. Then again, the nursing assessment, sometimes it is left as a separate document, and it not become the part of the medical record. So by implementing this, you need to ensure that the nursing assessment, nursing care plan, dietary assessments and plans, and physiotherapy assessment, etc., are part of the medical record, not kept in a department and is kept for storing. No, as a whole, the medical record will cover the all these aspects. Next slide, please. Next slide, please. Yeah, IMS 3, this we have already covered. Next slide, please. IMS 4, the standard talks about the medical record reflects the continuity of here. Here also no changes in the standards, but there are slight changes in the changes in the interpretations to bring more clarity in the implementation. Yeah. Here what we are, next slide, please. Next slide. Yeah. In this, what we are looking for is having examples related to content of the nursing care, nursing assessment, etc. in this. And again, the name of the receiving organization. When you are going for transferring the patients, we were talking about the transfer details. So here, in such instance, the name of the receiving organization could be recorded accordingly. Bit difficult, we do understand when you are implementing it, sometimes which is the hospital patient is going to be, you may not be having an idea. So the word used here is could be. As in the first section itself, Pavan Kapoor sir also explained that shall, could, all, what is the meaning of it. So please note down, if possible, and whenever it is available, the name of the receiving organization could be recorded as part of the medical records. If possible, that is could be. As a long time, this also may become slowly a part of the medical record. Yeah. Next slide, please. IMS 4F, the medical record contains copy of the discharge summary. Always there used to be a confusion among the assessors and the implementing hospitals whether an electronically signed out medical records can be acceptable or not. In this digital area, NABH also is moving forward. So we have ensured that electronically signed out medical records are also acceptable. If a hospital is with electronic medical records, then it is acceptable that it is signed out as a medical records. Yeah, next one, please. Here again, it is regarding how to write the death report. So here what we are added, there is a slight change in the interpretation, no change in the objective element, no change in the standard. We have ensured that now medical certificate of cause of death as per the international classification of cause of death shall be part of the medical record. You are aware, sometimes the medical cause of death report may be a separate file or it may be kept in the MRD. So henceforth, a copy of that is mandated to be part of the medical records. Yeah. Next slide, please. The organization maintain confidentiality, integrity, and security of records and data information. Here, next slide, please. Next slide. Next slide. Next slide, please. Can you hear me? Yeah. Next slide. Yeah. Okay. Here again, IMS 5C modified for better clarity. This was one of the objective element. There used to be confusion when it goes for implementation. So here now we have added preventive measures against cyber attacks on clinical electronic medical record data shall be in place. So how the confidentiality, integrity of security of electronic medical records are addressed by doing this? What measures you are taking? You have experiences, even major hospital had cyber attacks and lost all medical records. So before we used to tell you should have a backup. Now even for cyber attack, what system you are going to put it. Again, the organization shall ensure that patient confidential data, for example, lab reports, etc., is communicated through a secure messaging platform. By bringing digitalization, we are bringing more breach of confidentiality into the patient informations. For example, most of the medical informations like lab reports, etc., are shared through WhatsApp and through other means of messaging. And how the hospital ensure this is reaching only to the only to the concerned patient or patient authorized person. What system you have in place is what we are looking for by adding this particular modification in the interpretations. Yeah. Next slide, please. IMS 5D. It's quite slow. Next slide, please. Priyanka, the slide is not moving?
There's just a lag, ma'am. Just a minute, ma'am.
Yeah, no problem. Yeah, here comes. Here in IMS 5, again, the continuity of confidentiality, integrity, security of records and data information. We are looking again There is a mechanism to safeguard patient data generated from medical equipments and its access to authorized people. This is another challenging area. As established hospitals, we do know that the breach of security system comes even to the medical equipments, whether it is a dialysis machine or a monitor which has access to the USB port or anything, and who can take data from this. Sometimes the medical equipment engineers or the external engineers collect the data. Sometimes the research material is gone from this particular medical equipments with all the patient details data available. That includes even the lab equipment. So how the hospital bringing confidentiality and bringing safeguard patient data from medical equipments and its access is another change we have brought with the intent of patient safety and security. Next slide, please. Yeah. This include the points. What you need to understand is that the process when you are preparing a confidentiality SOP for the security of the information, there are points which we need to cover or include. Number one is disabling the USB ports of medical devices. If that is not possible, you need to define who is authorized to collect such data. Then restricting remote access and downloading data from medical equipment. We have always overlooked all these things in the previous standards. So covering that, now we understood the importance of such information. So we have added now restricting remote access and downloading data from medical equipment, and installation and updation of antivirus in medical equipment. Sometimes the system collapse and the previous records of patient details will go away. Example, dialysis machines, the monitors, electronic, monitors, ventilators, etc., etc. So how you are ensuring such data is taken as a backup from medical equipments on a timely basis. So you may have to have an SOP on this in details. Though we have not written guidelines, my sincere advice will be you need to have a guidelines, clear guidelines on handling of medical equipment related data, and it is part of your data safety measures. This can be also based on findings of risk assessment. So again, when you are going to prepare an SOP, the first standard instruction or intent will be doing a risk assessment. What are the data breach could happen in your organization, whether it is related to EMR or HIS or imaging services or of your medical equipment. You need to do a detailed risk assessment, and then only you should develop a process for such requirements. Next slide, please. Yeah. IMS 6, the organization ensures availability of current and relevant documents, records, data, and information, and provides for retention of the same. Here again, next slide, please. No major changes. Yeah, next slide, please. Yeah, there is no major changes in the interpretation also, but again, we have looked into the system documentation that only the current and valid version of the documents are available for use. This is about a document control. Always there is a confusion, how are we going to do the document control? Then hospitals come with the different modalities like control number or identification marks, etc., etc. But it is better to follow the ISO guidelines on when you come for the document control. Here what we have added, this is what previously also we were mentioning, and now what we have added, now the change what we have added is the system documentation. This required policies, procedures, and plans are available, and the staff understand how to access those documents which are relevant to their work. Now, what is system documentation? This is always a confusion when we say system documentation. People will start telling we have an SOP, it has a date of starting and end time, who verified, validated, and we assume that is end of the thing. Now, but here, when we say refer to system documentation, we are talking about a comprehensive set of written materials that describe the structure, functionality, operation, and maintenance of a system. When we say a system, it is either of a software application or hardware system or a combination of both. So this will require then how we are going to address this. This will include the process for developers, system administrators, users, and support teams. Examples include technical, user, operational, and process documentation. So when you have a digital health system or a software or a hardware, you need to put under these documents, under these terms. I'm going little extra on this explanation because more and more hospitals are going for digitalization of their systems, even if they are not going for NABH digital health. It is the need of the hour. Then ensuring patient safety with all this high-end systems, ensuring patient safety is NABH responsibility also. So we have put this. So under this headings of technical documentation, process documentation, user department documentation, and operational documentation need to be written down. And not only having this as a documentation, the concerned staff should understand how to access those documents which is relevant to their work. Next slide, please. Next slide. Yeah. Then again, in as IMS 6B, it is not mentioned here, but in IMS 6B, the MCA changed to National Medical Commission. Now, across India, this is what terminology we are using. So, NABH standards also in par with that, we have changed. That is in IMS 6B, a slight interpretation changes there, where we have added now MCA into National Medical Commission. Now, coming to the procedure for destruction shall follow relevant statutory provisions. It is always there is a confusion about who will be the approval authority to destroy the medical records, etc., or the other forms and format. You need to follow what is your state statutory provisions. Most of the time we follow the NMC guidelines on it, but still there is not much clarity on this. Based on the revenue records and all, you need to go with the state law. So please refer to the statutory and decide on your destruction. But please do remember, this need to be documented, and a process for what we are looking as NABH is that what is the process of retention, or what is the process of destruction of your documents, and how you are adhering to the written documents. Do remember, whenever NABH put an asterisks matrix and talk about written guidelines, always you need to remember, you need to have a written policy, and how you are mapping it with your practices, and how you ensure the evidences for adhering to that particular standard. This is what we are going to look. So please ensure you are, as per the relevant statutory provisions, you are writing a written document on this. Next slide, please. Yeah. The organization carry out, this is IMS 7, the organization carry out a review of medical records. Next slide, please. Yeah. The review shall be carried out. In IMS 7A, the medical records are reviewed periodically. Now, periodicity of the medical record review depends on your number and depends on the organization need. Based on the NABH guidelines on sample size, you need to do the periodicity of the review. and a checklist can be used. The review shall be carried out for physical and electronic medical record. EMR records were overlooked whenever there is an audit. People believe that once it is in EMR, there is no chance of mistake. But when we audit, you will see that there are chances. When you do a risk assessment, breach of data can happen. So please ensure that your sample size include physical, and if your hospital is completely EMR, it is much easier for you. You will define what are the content of the electronic medical records, and an audit based on a checklist could be used for this. Yeah, next slide, please. Next slide. Yeah, a checklist. I have already explained that. And IMS 7D mention about the interpretation. No major changes in interpretation. What we have added it, a checklist could be used for this purpose. That is depends on the organization policy and process, what type of checklist you are going to use. For this, my advice will be you will have to develop a content of the medical record. What are the content of the medical records, and what is the risk you have identified during the risk assessment, and based on that a checklist could be used for this purpose. Next slide, please. I'm getting a comment that slides are not moving. I hope it is moving. Yeah, the review records points out and document any deficiencies in records. It is in continuation of the IMS 7D. You need to review based on a checklist, and it should bring out the deficiencies in the record. For that, you can use the examples: final diagnosis not mentioned, incomplete OT notes in an operated patient, incomplete consent, missing signature, name and date and time for all entries, etc. As experience, all of us are sitting here is with a NABH implementation, part of NABH implementation in your own hospital. Sometimes the checklist become an yes or no, where final diagnosis mentioned, maybe yes, then again incomplete OT notes, sometimes it is written OT notes available, yes or no, then it become OT notes available. Then your report will show 100% compliance to the medical records. If you understand the intent of a medical record is to look for the deficiencies and how you are going to bring out the changes by doing a thorough analysis and corrective and preventive action. So preparation of a checklist is going to help you. That's why we have added using a checklist for medical record audit. Next slide, please. Next slide. Next slide. Can you hear me?
This was the last slide.
Oh, okay. Then say thank you, not should come. Yeah. Okay.
Okay,
Yeah.
okay, ma'am.
So
Thank you
thank
very
you.
much for taking up this session.
As
I
of
would now
now,
request.
yeah.
Yeah.
As of now, I'm happy this time my slide went on well. Yeah.
Yeah, ma'am.
Yeah.
Okay. Now I would request Dr. Mukta Nagpal, Assistant Director NABH, to enlighten us on further opportunities for participants.
Any question answer session after this or anything? A lot of questions.
After this, ma'am, we will take up after this, ma'am. A lot of questions have been answered also, but we will definitely
Yes.
take after this.
Yes.
So, good evening, everyone. I'm Dr. Mukta Nagpal, Assistant Director, NABH. So we trust that the session over the past 2 days have been insightful and have provided you understanding of the changes introduced in this latest edition. At NABH, we are committed to being an active partner in the quality improvement journey of our healthcare organizations. To support your continued development, we offer a range of programs and courses designed to strengthen your knowledge of core healthcare quality principles. So as we have a diverse group of participants today, including those at various stages of accreditation, whether you are in the pre-assessment stage, applicant, final assessment stage, or the already accredited hospital or surveillance or renewal assessment stage. But for those who are interested in a more depth exploration, we highly recommend attending the 3 days POI program, which covers the detailed process involved in the implementing the 6th edition of NABH accreditation standards. So we are conducting closed and open POIs both. So the details are there on the website. You can see on my screen also. So for some of the POIs, the registration are closed, but for 21st to 23rd Feb, the registration is still open. If you are interested, you can register over there. Additionally, we encourage you to explore the resource section on our website, where you can access recorded training sessions, webinars, and other valuable material. NABH also offers weekly educational workshop on topics such as clinical audit, continuous quality improvement tools, documentation for patient safety and quality improvement. So, and we strongly encourage you to enroll in this workshop by visiting the training and education section on our website. So we also have programs for Center of Excellence like Nursing Excellence, Emergency Department, and Stroke program also. So you can enroll in this program also. So thank you all for your commitment to healthcare quality, and we look forward to continuing this important journey together as we work towards advancing excellence in healthcare. So wish you all a very happy new year. Thank you so much. Thank you. Dr. Priyanka, over to you, please. And one more thing, your certificates for this course, you will receive within next 15 to 20 days.
Thank you, Dr. Mukta, for your session. I would now like to take a few questions which were asked during IMS chapter. Okay, there was Binyama ma'am, you're there in the session.
Dr. Pavan Kabur also. So, yeah.
Yes, Pavan Kapoor sir is also there for the session. Ma'am,
Yes, sir.
there have been questions regarding destruction policy. What should be the destruction policy, all these things. So
The
can you please enlighten on
organization
that?
shall develop, the organization shall develop a policy on destruction based on the statutory requirement. Ideally, though there is a confusion and people start putting it in the newspaper and all, it's not mandatory as per statutory requirement. If your SOP says that you are going to keep your documents for 5 years or 10 years or 6 years, this as a information, it should go to the patient. And before you are sending the clinic, especially the clinical records for dissection, a copy of the medical records shall be displayed in the hospital or in their website, and it is to be approved. It should be authorized by a person. The custodian of all clinical records or medical records of the patient is the clinical head of the organization most of the time. No, not most of the time. The clinician is in charge of it. In a bigger hospital, the clinical head will be in charge of the MRD and the medical records. In a smaller hospital, maybe it is the concerned doctor. So you need to develop a policy and adhere to that. And documented, the witnessed destruction should happen. That means there should be someone who witnessed that this medical records are, as per the policy, destroyed, and that document is kept for references in case of any legality or anything.
Okay, ma'am. There have been questions regarding can the MOU be accepted for software also?
Yes, yes, yes. All software copies also can be included in the policies. Yeah.
Okay, ma'am. There have been questions regarding transition plan. The transition plan is available on our website.
Yes.
You can go through that.
There is one
So,
question
they
on who can do medical record review audit. This must be done by an authorized person or a team of members, preferably based on your hospital policy, preferably who can understand. Now, when we were talking about the checklist, we were telling about the content of the medical record, completeness of the consent forms, operation notes, and all. Unless that person has some sort of a clinical background, they only will do yes or no questions. So preferably you need to have a team which comprises the clinical and nursing team. That is what the ideal scenario, but hospital can identify who can do the medical record or audit. With additional training, these people can, when I say additional, don't start going for another training. It is about what is the content, how to read those content. That awareness should be there, the person who is doing the medical record audit, review audit.
Okay, ma'am. They have also asked, do we need to have quality control numbers for electronically generated forms and formats, progress notes, medication orders, prescriptions, etc.?
Yes. When there is a change in the record format, especially I will rather, with my experience, I will tell, if you don't have a document control on your electronic versions, anybody can change anything to that. So that control number and revision rate can be inserted into the EMR also.
Okay, ma'am. I think these were the most of the questions they have asked regarding YouTube recording for these sessions. These will be uploaded on the official NABH YouTube channel, but it will take some time of maybe of 10 to 15 days.
Yeah.
Okay, ma'am. They have also asked retention period for various kinds of documents like pediatric case files, OP/IP files.
Don't put me in trap. Okay, there is always a confusion about pediatric. Pediatricians don't agree to destroy it till the age of 21. Especially certain type of genetic disorders will need long time therapies. So it should be based on the statutory requirements. When I say that, you need to consult your clinicians on regarding this particular cases. So you have to develop your own SOPs.
Okay,
Okay,
ma'am.
good.
Yes, sir.
Alice. Good evening, sir.
See, yeah, good evening. There is no at there was a council which was going through this system of various records that are being held in various countries. The retention time for pediatric records of people with genetic disorders, for those who have died, how much time OPD cases to be kept, how much time trauma cases to be kept, how much time the MLC cases to be kept. They are given a country-wise differentiation. Am I audible?
Yes, sir.
You are audible. Yes.
Okay. So they are given a country-wise differentiation. Okay, they are given a country-wise differentiation in that there's a this thing the minutes of the meeting of the council is available on the website. I will share with NABH. NABH will share with all of you. That shows what is India's stance on that. So far, only there are very few states who have come out with a retention policy for medical records without specifying whether they're pediatrics or not. Even the Medical Council of India earlier come out with in their code of conduct, in their ethics, they had come out with code of medical ethics. They had come out with a retention policy of 3 years for OPD and 5 years for inpatient and 10 years for medical legal cases. That was the Medical Council of India's guidelines in their code of medical ethics. Okay, I think the NMC has revised the code of conduct and code of ethics. I would request all of you to go through that. You can easily download it from the NMC website. You will get the NMC code of conduct. I found many of you writing what is the code of conduct for nursing and for distinct doctors. So for doctors, They've got the National Medical Commission Code of Conduct. For nursing, Indian Nursing Council has made a code of conduct. You can easily download those code of conduct. And for other administrative code of conduct, you can lay down yourself, or there are CCS rules from which you can copy and make it applicable as applicable to your organization. That was the code of conduct. And retention policy, well, Maharashtra has got one retention policy for records, and they also follow same almost that it is 3 years for OPD, 5 years for inpatient, 10 years for after the death, 5 years after that, or 10 years after that, and 10 years after the case has been decided, a medical legal case has been decided. But nationwide, we do not as yet have a firm policy. Till 2021, there was a parliamentary committee meeting on this, which have prepared their guidance document, but their guidance document has yet not become a legal document or a statutory document. There are certain Ministry of Health and Family Welfare guidelines, which some of you have quoted here, which are correct. So you can follow those guidelines as well. But in this document which is there, which I think I will share, I was privy to that document. So I'll share that document with NABH. They can share some of the contents with you. That is for your knowledge. Okay, then how it is to be made applicable, maybe sometimes in your states you are in a position of decision making. You can utilize this background knowledge to get a policy for your state, because health is a state subject in our country. What is worrisome to me? Worrisome to me that this is actually a program where you're supposed to be only told what changes are taking place from the 5th edition to the 6th edition. But what I am worried about, that many questions are being asked which we all should have known. And rightly so, they were not answered. So my request is that we do need to have, Priyanka, you may please note it down. Please bring it to the notice of the Assessor Management Committee, that we need to have some regular interactions based upon the concerns being faced by our assessors while understanding or interpreting some of the objective elements, or while understanding how they are to be implemented at the organizational level. Okay, so I know we are not prescriptive. Generally, none of the accreditation standards are prescriptive. There are prescriptions somewhere, but most of the time it is left to the organization to decide what are the practices. But we can only share the best practices. What is the best practice available? So my request would be that please note down the concerns which they have given here, where people want to know about material vigilance program. This has been existing since the last edition. So we should hemovigilance program, material vigilance program. So I think we can have a small knowledge sharing based a webinar for all our assessors. Over a period of time, we should organize such webinars to enhance everybody's knowledge, and let us be on the same page. Otherwise, we start interpreting the same thing differently and will come to different conclusions. So Priyanka, my request is please note down, we should have regular refresher training programs. And yes, we have doubt. There are certain people who are young assessors. There are some who are older assessors. Some young assessors are good at digital part of the technology. Some older assessors are good at, let's say, all the programs that have been existing in the past. So I think we need to collectively have a refresher course on regular basis to address certain observations that are being made here, which are actually not related to this migration. So can
Sure,
we do
sir.
that, Priyanka?
Sure, sir. We will be upcoming with that thing, sir. That is
So
already
you have
in.
noted down all the questions. We'll just find out what
Yes,
are
sir.
the common. I've also noted down the question. So what are the common areas of concern? And we can hold short webinars, 1 hour webinars on those issues,
Sure.
and address those issues which are creating doubts in the mind of the assessors.
Done, sir. We will definitely do that.
Okay. We should do that, because it's an ongoing process, and none of us are perfect. Let me be very honest. We all need to learn, and learning is a continuous process. So thank you all very much. You have asked wonderful questions, and you have asked some genuine doubts, which I should also be having, should I be as an assessor. So we'll try to address this. All the question answers will be put up to us. We will try to, all the technical committee members will.
Sir, you are not audible. Sir, you were not audible for some time.
I'm not audible.
Yeah, now you are audible, sir.
Okay, I want to know They have given so many questions, so how much time frame we can sit down as the technical committee and answer their questions based upon the doubts and send it to them?
Sir, we will definitely try to revert back within 15 days. We will definitely frame all the questions and revert them within 15 days. So.
Yes, just do that, because they should not go back from this program without getting an answer to all their queries. I know it is not possible to address them here, but let the technical committee take a call on all their questions and respond them. Even if it is not relevant to this migration, we should address the questions.
Exactly, sir. We will try to come up with short sessions on these also. We will try to incorporate them in our training sessions. Definitely, sir.
Thank you, Priyanka. Thank you, all of you. Thank you, all the faculty members, for taking their time out and sharing how they went about the changes and what are the major changes.
Thank you, sir.
Okay, and thanks to all of you from NABH Secretariat who have been, tirelessly working on this program for the last almost 10 days. So thank you all for all your efforts, and God bless all of you. Jai Hind.
Thank you very much, sir. I would like to thank all the faculty members, Binya Makurian ma'am, especially Air Marshal Pawan Kapoor sir for being the mentor for us always, and Dr. Rajiv Kumar sir, Dr. Sanjeev Singh sir, Dr. Monica Gupta ma'am, everyone, thanks a lot for coming and addressing all the queries and taking up such an informative and knowledgeable sessions. We thank all the participants. Without your attendance, it would not have been possible. Thank you very much for joining us. You can write to us for any further queries and also any questions. We will definitely try to respond back to all the questions that have been asked through chat section. We thank you all for your support and continued journey. Thank you.